Chitrakala, can we start?
Good evening, everyone. This is Chitrakala from Shield Healthcare. Welcome all the faculties and delegates. First, I wish everybody happy Ugadi and happy Gudi Padwa. Today, we are on the episode 4 of AMOGS Emergency Obstetrics Committee webinar with Societies of...
Chitrakala, can we start?
Good evening, everyone. This is Chitrakala from Shield Healthcare. Welcome all. I took immense pleasure to introduce Dr. Deepthi Gupta. Dr. Deepthi Gupta is the Secretary of Jabalpur Obstetric Gynecology Society and Secretary of all Madhya Pradesh Obstetric Gynecology Society. Dr. Deepthi Gupta is a FOXY Quiz Committee West Zone Coordinator and FOXY Gurukul Meda West Zone Coordinator. Dr. Deepthi Gupta is Associate Professor in NSBC Medical Center, Jabalpur.
Thank you, Chitrakala.
Is a consultant and unit head in Anku Fertility Clinic, Jabalpur. Now I hand over the session to Dr. Deepthi Gupta.
Thank you, Chitrakala. I welcome everybody to the 4th episode of AMOGS Emergency Obstetrics Committee webinar. And it is a matter of gratitude and happiness that AMOGS and MPOGS are working together hand in hand to disburse knowledge far and wide. At the outset, I would like to wish everybody a very happy Ugadi, happy Gudi Padwa, and best wishes on Chaitra Navratra. May all overcome the difficulties. May all see abundant happiness. May everyone's desires get fulfilled, and may all rejoice in every circumstances. Now I request everybody to please join in for a lamp lighting ceremony, followed by the session further. Chitrakala, can we please have the lamp lighting?
Kurutvam kalyanam arogyam dhanasampadam shubham kurutvam kalyanam arogyam dhanasampadam shatrubuddhi vinashaya deepajyotirnamostute deepajyotirnamostute shubham kurutvam kalyanam arogyam dhanasampadam shubham kurutvam kalyanam arogyam.
Thank you so much. Can I have the CV of Sneha ma'am, please? It is my privilege to welcome and introduce Sneha Bhuyar ma'am, who is a well-known figure to all of us. She has recently won International MS Signature Award for Phenomenal Leadership. She has also won Asia GCC Award. She's won Dr. S.N. Malhotra Individual National Award, Dr. Durusha Distinguished Community Service National Award in 2022, Individual Award as Champion of FOXY for 2 consecutive years in 20 and 21, followed by Dhira in 22, Anandibai Joshi State Award by Government of Maharashtra, Lokmat Healthcare Excellence Award in 2020, delivered more than 300 talks with more than 10 keynotes and orations, and moderated more than 100 panels. She's also contributed more than 30 chapters and articles in various national publications. She has held many important posts like the FOXY Breast Committee Chairperson 19 to 21, Government Council Member of ICOG 2021 to 22, National Adolescent Trainer, WHO FPAI Certified National Expert with UNICEF, Peer Reviewer of Jogi, AMOGS Chairperson of Medical Disorders Committee for the years 22 to 24, AMOGS Chairperson for Emergency Obstetrics Committee for 24 to 26, Mission Pink Health Committee and Convener, PCPNDT, CEPHOG Working Group Member, Founder President of ISOPAR Vidarbha Chapter, and President YOGS 2007-2008. Also founder Clinical Secretary of Yavatmal OBGY Society in 2003, and life member of so many prestigious organizations.
Thank you so much.
Thank you, Sneha ma'am, for the opportunity, and I welcome you for the proceedings.
Thank you so much, Dipti, for that kind and generous introduction. A very good evening to one and all. A very good evening, especially to all of you, and a warm welcome to AMOGS Office Bearers, AMOGS President Dr. Kiran Kurtakoti, Dr. Bipin Pandit, the Secretary of AMOGS, Dr. Rajendra Singh Pardesi, our mentor, Dr. Immediate Past President of AMOGS, and the entire team of AMOGS Office Bearers. Madam Jyoti Bindal, the immediate past president of AMOGS as chief guest, and Madam Kavita Singh, the president of AMOGS as the guest of honor. Revered speakers for today, Dr. Sarita Bhalera speaking on abruptoplasty, and Dr. Mahesh Gupta speaking on uterine conservative surgery, in the management of postpartum hemorrhage. The expert chairpersons and the well-known figures in Madhya Pradesh, Dr. Rosa Ulai, the past president of president of Jabalpur, of Madhya Pradesh. Our learned panelists for today, Dr. Rinda Joshi, President of Gwalior right now, Dr. Pradnya Harshe, Dr. Shabana Sultan, the Secretary of Gwalior, Dr. Jagrati Nagar, and also the Dr. Nidhi Rathi, Dr. Renu Jain, Dr. Taruna Sharma, Dr. Swati Patel, Dr. Richa Pacharia, and of course, I hope I have not forgotten anybody. Last but not the least, the convener, Dr. Brijbala Tiwari, who has, helped me a lot in coordinating and conveying this program, and of course our dear friend Dr. Dipti Gupta, who has taken taken all the pains and has done all the hard work for the wonderful coordination of this program with the faculties and with the technical person as well. So I welcome all of you for this auspicious occasion. I wish all of you the very happy Gudi Padwa and of course Ugadi. With this, I take the pride and privilege to welcome the AMOGS office bearers, and may I have their blessings and words of wisdom. So may I invite Dr. Kiran Kurtakoti, who is the president of AMOGS. I think Dr. Kiran had some other program also, so he will join back in some time. He's the president of AMOGS, and just for his introduction, the ex-chairperson of AMOGS and FOXY MTP committee, and of course he has various awards and publications to his credit. So Kiran, if he is available, I think we can have his words. Otherwise, can we have Sir CV, Dr. Rajendra Singh Pardesi, who is the immediate past president of AMOGS, the past chairperson of Food and Drug Medical Surgical Equipment Committee, and past vice president of FOXY.
It's okay, we can skip that.
Sir, over to you, sir. We are eager to listen to your precious words of guidance.
Good evening, everybody, and happy Gudi Padwa. Respected chief guest, Dr. Jyoti Bindal ma'am, guest of honors, Dr. Kavita Singh, and our AMOGS office bearer, Dr. Kiran Kurtakoti, Dr. Bipin Pandit, Dr. Mehendale, and our seniors, Dr. Ragini Agarwal, Dr. Sarita Bhalera, Dr. Rosa Olia. First, I wish to congratulate Dr. Sneha Bhuyar, our active AMOGS chairperson of Emergency Obstetrics Committee, for organizing this webinar on APH, PPH, and near-miss cases. This webinar is really important, which will help in reducing maternal mortality rate, as hemorrhage contributes a major cause of maternal mortality. With the eminent faculty like Dr. Sarita Bhalera, Dr. Mahesh Gupta, Dr. Sneha Bhuyar, and chairperson Dr. Rosa, Dr. Mani Dr. Aruna, Dr. Renu Jain, Nidhi, Dr. Swati, Dr. Richa Paharia, Dr. Brijbali, Dr. Dipti. I think this will be a great event. And we are very happy to join with Madhya Pradesh societies, as they are our neighbor societies. I think we should take care of all neighbor, and we should go collectively and jointly with all programs. So I wish every success to Dr. Sneha Bhuyar for her future endeavor in FOXY as Vice President FOXY, and also Dr. Brijbala is there also, to Dr. Brijbala Tiwari for Chairperson for Environmental Health Committee in this forthcoming elections. Wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you, sir. Thank you so much. I think Dr. Kiran will join in a short while. So by the time I just take this opportunity to introduce Madam Jyoti Bindal as chief guest for this program. And Madam, I don't think there is any need to introduce you, such an illustrious personality with highly decorated CV, Madam. Madam is the Vice Chancellor of the Aurobindo University, and she is, has so many publications and orations to her credit. Of course, she has the variety of posts held as she's the ex-dean and CEO of MGM Medical College Indore, ex-director of Gwalior Mansik Arogya Shala.
I think we'll let it go, Sneha, as you said.
Yes, definitely. And in fact, it is our pride and privilege to have you, Madam. Over to you for your precious words.
Thank you so much, Sneha, and it's a pleasure and an honor to be here today. And, I will begin by a totally unconventional way. I think the relationship with Sneha has passed from a professional friendship to a personal friendship. And that's why I'm so thankful, Sneha. It's a pleasure to be. And that's why I said, yes, the minute you said, it's a pleasure to be in anything organized by you. I'm very thankful and I feel honored to share the platform with AMOGS office bearers, Kiran. Definitely, Dr. Bipin Pandit is not there, but Dr. Rajan Pardeshi is again. Sir, it's an honor to be on the same platform as you. I'm so happy to be here with Kavita, who has taken over the reins of AMOGS, our Madhya Pradesh societies, in a much, much better way than anybody else before. And she's absolutely began with a bang, I have to use this word. So very happy to be with you, Kavita.
Thank you so much, ma'am.
The
Thank you
more
so
I've
much.
started knowing Brijbala little by little, but I keep on getting impressed. And yes, it's a great personality, and we do see a future chairperson in you, Brijbala. I do hope and wish you all the success. I don't have to say anything for my friend Rosa, who's we go back 2 generations. So yeah, she's close to heart. But then Manik, Anita, everybody's here. Rachna, whenever I think about you and talk about you, I always think कि एक बरगद के ट्री के नीचे कितना prosper करना कितना मुश्किल होगा. With the kind of mother and your personality of your mother, my God, the way you've risen above all that and you have really shown in your own way. It's a pleasure to meet you even virtually, but I'm looking forward for your visit to Indore as you promised me. All of us have heard Sarita before, and yes, we are all impressed and we are looking forward to your talk. Dr. Mahesh Gupta, again, I have seen his surgery more than once, and he's absolutely the right person today to talk of conservative management of PPH. Sneha and Ragini are moderating and being expert for an amazing panel. And of course, people like Vranda, Pradnya, Shabana, Nidhi, Renu, Taruna, Swati, Rich. I don't think, Sneha, you could have picked up a better range of panelists, I would use the word. But one thing I want to add here very importantly is that I'm sure all of you are being literally cluttered by at least 5 to 6 webinars every day. I don't know, I'm oversaturated. And in this, the webinar of emergency obstetrics really comes like a breath of fresh air, because this is something most of us deal in day-to-day life. And as I always say, that the challenges of motherhood when every minute counts, we want to ensure the safety of mother, child. That's something totally different than any other aspect of obstetrics and gynecology. And so this is the time I would like to remind all of us for our role and urgency and importance of our role. Because we are not just healthcare providers, we are actually guardians of life. And we are tasked with this noble responsibility of bringing a new life in the world, and not only that, safeguarding it. Our resolve is always tested in the face of all those emergencies we face. And I remember one of my colleagues telling me that when we deliver in a normal delivery, it feels that we are ourselves giving the pressure, So all of us have experienced that moment in our life. And so all I can say is that together, let's reaffirm our commitment to excellence and commitment to continuous learning, which is the platform today, and to innovations in the field of obstetrics. It's a pleasure to share the knowledge and also harness the power of collective expertise, which we are going to see how to tackle the challenges. And by working hard in every day-to-day learning, I think we'll overcome most of the challenges of near-miss situations. And once again, Sneha, thank you so much for giving me this opportunity to share this moment with all of you. And it's a pleasure to be here. Thank you.
Thank you so much, madam. I know you have been always so supportive and so positive about me, and it's been a long association with you, and that's the very reason. Thank you so much for all the appreciation and words of support from your side. Thank you so much, madam. Actually, we have already introduced our dear friend and AMOGS President, Dr. Kiran Kurtakoti, but meanwhile we had I think he has joined for some other webinar, and I can see him back here. So welcome, Dr. Kiran Kurtakoti, the AMOGS President. And we have already introduced you, Kiran. We would like to listen to
Thank you. Thank you. As the host of this particular webinar, I welcome all of you on this platform. I really, today Chief Guest, Dr. Jyoti Bindal, a long association with Jyoti ji since for the past about 25 years. Dr. Kavita Singh, today's guest of honor. Dr. Pardeshi sir, immediate past president of Foxy. All my friends in Foxy, Dr. Brajbala, Dipti, Dr. Rachna ji, Nidhi, Sarita, Rosa, and everyone. And Sneha, I really must congratulate you because the way in which you passionately do these workshops on emergency obstetric care, I mean, these are really overwhelming. As Dr. Jyoti ji said that, among the clutters of webinar, this AMOC webinars are really a breather because, they give you a fresh perspective into how you can save the mother's life every day. Yesterday, while Suvarna Khadilkar was installed as the AMOG's president, I had the opportunity on giving the talks on all these, how to achieve hemostasis at C-section. So all these issues came up, and I think if Mahesh Gupta is there, I think Mahesh stage was also mentioned, Dr. Anand stage was also mentioned. So really a fantastic work that you are doing. And I also would like to thank Dr. Jyoti and Dr. Kavita Singh for getting associated with AMOGS in the AMOGS 2024 conference. So thank you for the initiative also. And AMOGS is inclusive and all inclusive, and we would like to remain the same. And I really appreciate all of you for that gesture. And best wishes to you, Sneha. And Brajbalaji, I also heard that you are planting a lot of trees. Do plant a lot of trees after every birth. And please give us an opportunity to receive a pauda from you whenever you get installed as the chairperson.
Thank you so much.
Thank you.
Thank you so much, sir.
So thank you so much, Dr. Kiran, for that wonderful words, as well as, the insights into the subject of maternal mortality, how passionate all of us are working for the emergency obstetrics. With this, I invite Madam Kavita Singh, the president of AMOGS. Madam is the professor and head of Department of Obs-Gynae in NSCB Medical College, Jabalpur, and she's the WHO master trainer for colposcopy and a gynae oncosurgeon. I'm sure she has lots to talk about her, but Madam, we would prefer to listen to your precious words. And over to you, Dr. Kavita, for your words of wisdom.
Thank you. Good evening. Namaskar. Shubh Navratri, Shubh Gudi Padwa to each one in the webinar and to all the listeners, participants. At the outset, I would like to thank you, Dr. Sneha, for inviting us and being part of this. And I would make a request to you that you have put in the banner that it is AMOGS with societies of MP. So you put it as an MPOX.
Yeah, actually it is AMPOX, but I think
Yeah.
that is by the technical person.
Yeah, because
We
all
have
of
to
the
say it as AMOGS as AMPOX.
yeah, because the friends, all those who are here in the panel, they are all renowned people of MPOX. So put it next time whenever you just take care of that thing. And my humble regards to Madam Jyoti Bindal. Madam, thank you so much for kind words. इतना appreciation हो जाता है तो लगता है अभी और काम करना है. So I take this opportunity to invite on the behalf of Madhya Pradesh MPOX Society everyone on the state conference that is on 27th and 28th of April. तो आप लोग सब लोग आइए और सभी लोगों को मेरा नमस्कार. डॉक्टर परदेसी, डॉक्टर ब्रिज, डॉक्टर सरिता, डॉक्टर महेश गुप्ता, डॉक्टर अनीता श्रीवास्तव, Dr. Rosa, Dr. Rachna, Dr. Manik, Dr. Kiran, Dr. Nidhi, and everyone, Dr. Vrinda. And I'm so happy to see the energetic secretary of MPOX, Dr. Dipti Gupta, as an MOC. So all the best to you, Dipti, and all the best to you, Sneha, because we are looking forward to listen the learned speakers. So I would stop here. Thank you so much.
Thank you so much, madam, for all your precious words and, of course, guidance and support from your side. In fact, it's been a long association with AMPOX, Madam Jyoti Bindal. We have been, regularly in touch with both the organizations together. I think it was the technical error, and Braj was little stressed out because her mother was not well, and that's the very reason I think there's a little, I think, technical error on the flyer. So definitely we shall take care of it, madam. And with this, I thank all the dignitaries, respected Madam Jyoti Bindal as chief guest and Madam Kavita Singh as guest of honor, amongst office bearers, respected President of AMOGS, Dr. Kiran Kurtakoti, Secretary Dr. Bipin Pandit, our immediate past President, respected Dr. Rajendra Singh Pardesi sir, and all the dignitaries here who have graced this occasion. I'm really thankful from the bottom of my heart, and thanks for all the love and affection showered by you, and thanks for all the support. We would like to go ahead with the academic session, and for this I hand over to Dr. Dipti Gupta and Dr. Braj. Over to you, Dr. Braj.
Thank you, Dr. Sneha, and good evening and happy Chaitra Navrat to everyone. So it's a privilege to be part of this important webinar by MPOG and AMOGS, and I'm thankful to Dr. Kiran sir, Dr. Rajan Singh Pardesi sir, Chief guest Dr. Bindal madam, our guest of honor, my dear friend Kavita. And after these blessings, we are going to start our academic session. And for that, I'm inviting our very, very dynamic, beautiful chairpersons, Dr. Rosa Olia madam and Dr. Manik Palse madam. So Dr. Rosa, we know very well. She was the past vice president of Foxy. She's director of Olia Hospital and Research Center, Gwalior. And she's President-elect Gwalior OBGY Society for 24-25, Chairperson SBC Madhya Pradesh, Member National Screening Committee Family Planning, Association of India, Fellow and Member Board of Governing Council ICOG, and Chairperson Adolescent Health Committee 2012, FIGO representative WHO session at the FIGO, and so many things. And madam is so dynamic. So I welcome you, ma'am, to chair the session. And our next chairperson is Dr. Manik Panse, madam. She is immediate president, Jabalpur OBGY Society. She is very senior obstetrician from Jabalpur city, and she is director, Anand Multi-Speciality Hospital. And madam is executive council member, BOS Food and Nutrition. So we welcome you, ma'am. So over to you, both the chairperson, for a very, very important talk by Dr. Sarita Bhalera ma'am. Over to you, Rosa madam.
Thank you so much, Dr. Brijbala Tiwari, for the wonderful introduction that you have given. Your CM is always wonderful, and I wish you all the best for your upcoming elections. Sneha has been a good friend. We worked together in adolescent committee when I was chairing, and you worked throughout to get such good awards. So you deserve it. Wish you all the best, Dr. Pardesi and Dr. Kiran, who have been working at. I'm so happy that you joined MP together. Kiran, we worked together as chairpersons, and it's so lovely that, to see you come up so well. Dr. Pardesi, always a good guide. I do remember all the good advice, you and Ajay Mane together. So make a good pair. And of course, we have Deepti and rest of the friends here, and Dr. Jyoti Bindal, who's been just very kind with her words of, welcome. And Dr. Kavita, of course, our present AMPOGS president. So here we have, I'm so happy to introduce my very good friend, Dr. Sarita Balarao. Sarita, I know you since you were the joint secretary of FOXI. You worked so hard and so efficiently that now to see you coming up so well in FOXI is a proud moment for all of us. I'm so happy you've joined us in Madhya Pradesh. Well, you're everywhere in the governing council, ICOG. Of course, I mentioned you were the joint secretary of FOXI 2017, past president of the AMWI Mumbai branch, which now Gwalior is now a member of this organization. You've been the chair to the AICC RCOG West Zone, the quiz committee chairperson, FOXI. You have done such wonderful work in this committee. You've been the past chapter secretary of IMS in Mumbai. And of course, immediate past president, Bombay Obstetric Gynec Society, which is such an important, large organization that we have. And at present, you're working as an obstetrician and gynecologist to Breach Candy, Reliance, H&H, Saifi, Bhatia, and Vadia Maternity Hospital. A beautiful, wonderful person at heart whom I know. Sarita, over to you for your important lecture. We are waiting. It's very interesting.
Thank you very much, Dr. Rosa, for that kind and generous introduction. And can you see my slides?
Yes, but not
Yes.
Yes.
Yeah, is it in slideshow?
No, it's just randomly placed.
One second. I'm just putting it into slideshow. Is it now in slideshow?
Yes, perfect.
Yes, it is.
Yes, I'd like to start by thanking Dr. Kiran Kurtakoti and Dr. Rajendra Singh Pardesi. Thank you for involving me in AMOGS. Thank you to Dr. Sneha Bhuyar, our master organizer. She's just done a very, very successful certificate course in emergency obstetrics for the ICOG. And to Dr. Brijbala Tiwari and to all my friends from MP, Madam Jyoti Bindal and Dr. Kavita Singh, so many friends. It's really a pleasure to be here. And my topic for today is abruptio placentae. So abruptio placentae, as we all know, is premature separation of the placenta from the uterine attachment before the delivery of the fetus. So it could be antepartum or it could be intrapartum. And we really divide it practically into three groups. It could be preterm, it could be near term, 34 to 36 plus weeks, and term 37 weeks gestation. And I think this definition, if we know in our mind, then we are very clear which category we're dealing with. The hallmark presentation is vaginal bleeding, abdominal pain, and abnormal fetal heart. Now, what is new in the pathology? Abruptio has always been there for a long time, but today we know in the pathophysiology that it's not just an acute event. There is a long-standing chronic process of thrombosis, inflammation, infection, and a vasculopathy. There is a defective spiral artery remodeling which starts very early in pregnancy. Maybe placental infarcts also. Some problem in trophoblastic invasion, and some reason we have vascular endothelial growth factor increased. And typically this is associated with preeclampsia and with fetal growth restriction. So what I'm trying to say is that it is one and the same problem. Now, what really happens is that there is a vascular problem, And then there's a sudden event. There's an inciting event. There is some mechanical or shearing force. It may be abdominal trauma. It may be rapid decompression after amniotomy. It may be vaginal delivery of the first twin. And this opens the intravascular channels for these thromboelastic substances. So if you look at my diagram, there's a rupture of the maternal vessel, there's a bleeding at the decidual placental interface, and there is detachment of the placenta. It affects 0.5 to 1% of pregnancies. But when we look at chronic hypertensives, the risk is 3 to 4-fold higher risk. With preeclampsia, the risk is 4 to 6-fold higher. Even pre-gestational and gestational diabetics, there's a higher risk. Tobacco smoking and cocaine and marijuana consumption, iron deficiency anemia, folate deficiency, hyperhomocystinemia, PPROM, chorioamnionitis, oligohydramnios. And now we have some evidence also that mood disorders, anxiety disorders secrete more cortisol, serotonin, beta endorphin, and this also may predispose to a greater chance of abruption. But the silver lining is that there's a 19% lower risk after folate supplementation, so we must all supplement our patients. So I'm trying to separate acute abruption from chronic abruption. In acute abruption, there's a sudden vaginal bleed. This is bleeding from centrally located large arteries. And these are patients who require urgent management because it's a torrential bleed and they destabilize. But in chronic abruption, there are recurrent episodes of moderate bleeding. These are peripherally located veins. But these patients require additional fetal surveillance and carefully timed delivery. As I said earlier, vaginal bleeding and abdominal pain are the hallmark symptoms. We have to rule out placenta previa and excessive show. Remember, in concealed abruption, there will be no overt vaginal bleeding, but there may just be small quantities of bleeding. And intrauterine fetal demise is a very, very important feature of this abruption. It may also lead to coagulopathy. So one must keep a high index of suspicion when there are fetal heart rate abnormalities and rapid labor progress. What about ultrasound? Ultrasound sensitivity is not very good, 60 to 80%. We may still miss 20% of cases, but specificity is high, 100%. So if they tell you that there is intraplacental collection, retroplacental collection, subchorionic collection, the placenta is looking much bigger than it should, then yes, there has been abruption. But if they tell you that no, everything is normal, nothing is seen, it could still be an abruption. Now, it's interesting to know the grading. In grade 0, it's an asymptomatic small retroplacental clot. In grade 1, there's vaginal bleeding, uterine irritability and tenderness, but no maternal or fetal distress. In grade 2, we have vaginal bleeding, uterine contractions, and signs of fetal distress, but no maternal shock. And in grade 3, there is severe bleeding, uterine hypertonus, wooden hard or Cuvier uterus, abdominal pain, maternal shock, coagulopathy, fetal distress, or death. So I think that it's interesting and important to grade our patients. So here we look at preterm abruption first. And here in preterm abruption, what do you do? Outpatient or inpatient management as individualized, corticosteroids, yes, yes, yes. Additional fetal surveillance in terms of non-stress test and biophysical profile and Doppler. And please look for other factors like fetal growth restriction, preeclampsia, and take them to 36, 37 weeks and deliver because we don't want an acute event. When we are looking at near term and term, there we want to stabilize the mother, check her vital signs, urine output, mental status, check the fetal heart rate, do a coagulation profile for platelets, PT and fibrinogen, blood group cross-match, Kleihauer Betke test. Abruption is notorious for causing an excessive feto-maternal leak and patients becoming isoimmunized. No tocolysis at all. Do not postpone the delivery for steroids. Yes, give steroids. If you want, you can even give Maxal for neuroprotection, but don't postpone the delivery. If there's fetal heart rate distress, deliver the patient as quickly as possible. And magnesium sulfate, there isn't 24 hours, so basically only for seizure prophylaxis. What are the typical fetal heart rate patterns? We get marked fetal bradycardia with absent variability, or you can get fetal tachycardia, minimal or absent variability. Any of the signs, variable, late, prolonged decelerations, sinusoidal heart rate, tocodinometry will show a continuous increase in the uterine contractions, increased resting tone, and tetanic or high frequency but low amplitude contractions. The severity of fetal heart rate changes corresponds with severity of abruption. And I still remember in Wadia Hospital, my boss used to say, if there is an abruption which has caused an IUFD, you're dealing with a very serious abruption. So the worse the fetal heart ranges, the more the abruption and the more serious the patient. Packed red blood cells to be given improve the oxygen carrying capacity, and hemoglobin less than 7 gram% is an appropriate transfusion level. FFP for coagulation factors and fibrinogen, IV fluids, crystalloids and albumin, cryoprecipitate for hypofibrinogenemia and maintain fibrinogen levels at 50 to 100 milligram%, and platelet goal at 50 into 10⁻³. So each of these components, blood component therapy, is a very important part of managing this thing. Today, in some centers, we have more sophisticated methods such as viscoelastic testing, thromboelastography. These are very accurate measures of coagulation, and they really tell you, they analyze the clot and they give immediate results in 10 minutes, 15 minutes, and they can tell you exactly what to infuse, whether FFP or cryo or platelets or even tranexamic acid can be given. So this is something which is available in transplant centers and higher centers. Now, coagulopathy is the most serious complication. Abruption is the most common cause of DIC in pregnancy. Typically, low platelets, prolonged PT, PTT, and low fibrinogen will be seen. A mild reduction in platelet count, but normal or mildly reduced fibrinogen in the acute phase. By the time the prolongation of PT and PTT starts, there is depletion of more than 50% coagulation factors, and clinical bleeding starts when the depletion is 50 to 75% of coagulation factors. So once you see a mild reduction in platelet count and a mildly reduced fibrinogen, these are the warning signs. 5 to 10% of IUFD is due to abruption, severe abruption, and here vaginal delivery is preferred even if the Bishop score is good. But if there's a previous scar, patient is not in labor, you may have to individualize treatment. The story doesn't end there, and these are the patients who have an increased risk of mortality from cardiovascular disease and cerebrovascular disease. And the question is pregnancy a stress test for them? Perhaps. They already have an underlying coagulopathy that manifests in pregnancy, and later on in life also they have these long-term complications. And remember that abruption and cardiovascular disease share the similar pathway where there is some disruption of the vascular system and hemostatic defects. When we look at perinatal outcomes, the most severe problem is the preterm deliveries, then fetal growth restriction, and abruption, unfortunately, because of the preterm deliveries, it results in a 6 to 10-fold increased risk of cerebral palsy. What are the recurrence risks? With one abruption, there's a 10-fold increased risk of recurrence. With 2 abruptions, there's a 25-fold increased risk. And what we can do is to counsel them, give them folic acid, give them multivitamins, and watch very carefully for preeclampsia through the pregnancy. Thank you very much for a patient hearing.
May I request
Hello. Can just thank you, Sarita. I know you're in a hurry to go, but I think
the people.
there's somebody, I think. So, Sarita, thank you so much. You did mention about the good nutrition, folic acid and multivitamins to be taken. And I think prevention, there are certain things in your hand to take care of the pregnant woman with a hemoglobin, because whatever happens next, a lot depends on how immune she is, how her body is strong enough to withstand But again, pregnancy is a stress to many metabolic disorders in pregnancy. Thank you so much, Sarita. I think my co-chair, is she here? She would like to add on something.
Nothing. She has covered so well. I just don't want to add anything.
Yeah, thank you. So wish you
Hello.
all the best. Yeah.
I know. All the best. Brijala. I'm so sorry. There was some technical glitch. So I joined late. Okay. Thank you.
Ma'am, you can give your expert comments. Manik
I
ma'am?
know every day this abruptio is very common. You should be watchful. You should be, even anemia should be taken care. BP should be watched regularly. Watchful expectancy. Everything is same. You have to be cautious. And you can, if you can prevent all such things to occur, that will be better. Thank you. Can you hear me?
Yes, madam, we can hear you. Yeah, very clearly.
Okay, because there is some problem. The weather is so beautiful in Jabalpur. It's raining.
Lucky, it's so hot in Gwalior.
No, it's raining. It's so beautiful. Dipti, pakka na? It's raining
Yes.
so much.
So thank you so much. Dipti, will you?
We can go ahead now.
Yes. So we are moving ahead with the panel first, right, Sneha ma'am?
Yes.
So
Dr.
Chitrakala,
Manoj,
can you
join
please
after
have the series of the moderator and the subject expert?
I'm already introduced, my dear. You
Yes,
can
ma'am.
go ahead with the panelist introduction.
Yes, ma'am. So Sneha ma'am's introduction we've already had, and our subject expert for the day.
Rajani will not be able to join. That's what she just conveyed me. She had joined for the inauguration. Yes.
Okay, ma'am. Okay, ma'am. So can we move forward, Chitrakala?
Yes.
Our esteemed panelists for the day are a dear respected teacher for me, respected Vrinda Joshi ma'am. Ma'am is professor and head in Department of Obs and Gynae, Gajra Raja Medical College, MP. She did her education from Jivaji University, Gwalior, with many gold medals. She's been trainer in a lot of offline and online courses, including Mahila Yaun Utpidan Shakti Shikayat Evam Unmulan Samiti, member of Medical Board for MTP, many awards and publications, especially pertaining to medical education, ICMR course on medical genetics and counseling, and lifetime memberships of many esteemed organizations. And almost everybody who has worked or studied in Gwalior knows Madam for being a absolutely gentle, being a very meticulous teacher who is always there, going to any extent for the patients. Welcome, ma'am. Next, please. Again, my teacher, Shabana Sultan, ma'am, who is a professor in Department of Obs and Gynae and also head of department at present. Madam is also the secretary of Bhopal OBGY Society at the moment. She's presented many papers and is a regular faculty at a lot of zonal and national conferences. And she's held various posts in Bhopal OBGY Society in the past. Welcome, ma'am. Dr. Jagriti Nagar, another esteemed teacher from Sagar Medical College. She's also the president of Sagar OBGY Society. She's associate professor in Bundelkhand Medical College and has been a regular faculty member. She's winner of all 4 national awards as president Sagar OBGY Society in 2017 at Ahmedabad AICOG. Must be one of a record, I think. Welcome, ma'am. Dr. Nidhi Bajaj, who's the secretary of Katni OBGY Society, a very, very enthusiastic, dynamic, dear friend with, again, a regular faculty member and with publications to her credit. And she's also interested in infertility and endoscopy. Welcome, Nidhi. Next, please. Dr. Renu Jain, who is professor in Department of Obs and Gynae, GRMC Gwalior, again my alma mater. She's also the secretary of Gwalior OBGY Society at present and has held various posts in the past with more than 17 years of experience in undergraduate and postgraduate teaching. And she's also been part of different workshops and conferences. Welcome, Renu ma'am. Dr. Taruna Sharma. She's secretary of Sagar OBGY Society and consultant gynecologist at Sagar with interesting hobbies of traveling and listening to music. Welcome, Taruna ma'am. Next, please. I think that is the galaxy of stars that we have as panelists for the day. Oh, we have a very dear person, Richa Paharia ma'am from Narmadapuram. She she's class 1 gazetted officer at District Hospital Narmadapuram, and she has had more than 20 years of experience as senior gynecologist in District Hospital Narmadapuram. She's also the president of Narmadapuram OBGYN Society at present. And she has special interest in communication, and she's been faculty at different conferences and webinars, and she has expertise in high risk pregnancy and cancer prevention, and she's doing a lot of work in preventable obstetric and gynecological morbidities. Welcome, Richa ma'am. So over to you, Sneha ma'am, and we are all eager to listen to another engaging, interesting. Dr. Swati Patel is also with us as part of the panel. She is also from Sagar. She's presently the secretary of Sagar OBGY Society, and in the past she was in Jabalpur and held the posts of joint secretary and treasurer. And Dr. Pradnya Harshe ma'am, who is currently the president of Jabalpur OBGY Society, also director of Harshe Hospital, a very, very loving and optimistic person. Welcome, Pradnya ma'am.
Thank you. Yes, thank you so much, Dr. Dipti, for that, wonderful coordination as well as, cooperation, I would say. And thank you so much for the introduction of all the panelists. Without much ado, I would like to go ahead with the subject. I hope you can see my slides and you can hear me.
Yes, ma'am.
Yeah, so Dr. Mahesh Gupta, because he's has some other engagement as well, so he will be joining after this panel discussion. And I'll just take this opportunity to welcome all the panelists, jumbo panel with, of course, a very quality panelist, learned ones. I would just start, just give me a moment. Yeah, so friends, near miss. So this terminology we have borrowed from the airlines industry, and it tells you what's the gravity of the situation and the urgency of intervention that is necessary. It is actually defined as a critically ill pregnant or recently delivered woman who would have died had it not been her luck and our good care on her side. So, near miss is also labeled as severe acute maternal morbidity, and it is labeled by WHO, and according to WHO, almost 8.23% of SAMM is preventable. And that is why, friends, we suggest that near miss case scenarios, in fact, should be discussed in the clinical meetings also, so that we learn. So when we talk about maternal morbidity or mortality rather, it's not the rates and ratios, not only the numbers and figures, friends. These are women whose faces we have seen in the phases of distress, agony, and despair. And these faces continue to haunt our dream. That is how it has been expressed by the Professor Dr. Mohammad Fatullah, who's the past president of FIGO. Looking back over the clinical times, one tends to forget the failures and take it for granted only the success. So it's the failure which stand out like keloid scars, never to be forgotten for the person who has experienced, and hopefully warning for others. That is how it has been expressed by the Ian Donald. I'm sure all of you will agree to me that considering the demographic change in the obstetric population, these near-miss morbidity, near-miss maternal morbidity or near-miss case scenarios, they are, the number is also increasing and the spectrum is also widening. All of you know the reasons. I'm not going to read this. Every case, normal labor, when you say, or normal delivery, it's only a retrospective diagnosis. That is how it has been even mentioned in the textbook of obstetrics. So normal labor or delivery can turn into a critically ill patient anytime, and that is why every case is a new learning for all of us. So friends, never stop learning, because life never stops us teaching. So with this, we would go with the first case directly. You have this second gravida with previous LSCS done 1.5 years back. She comes to you with 7 days overdue. Pregnancy test is positive and she wants to go for medical abortion. So the doctor prescribes her the empty pills and calls her for follow-up after 7 days. On 6th day, around 11 o'clock at night, she's brought by her relatives in a collapsed state. And, when you examine, you find that she's got severe tachycardia. Her blood pressure is only 70 millimeter of mercury systolic. Pallor is plus. And, on inquiry, you find that she just gives a history of spotting and, occasional fainting attacks or, giddiness. So what is your differential diagnosis? I'm sure Dr. Vrinda Joshi, you will take all of us thoroughly through these case scenarios. So what is the differential diagnosis here, and what investigations would you like to do for this patient, and how would you manage this patient? I'm saying, please, explain this to the house, how you explain it to your students.
Okay, thank you, Dr. Sneha, for the question. Now, from the history only, we gather that this is a woman who has had a pregnancy test positive, and from our experience, we know that pregnancy test positive in the early days, nobody is certain whether it is an intra or an extrauterine pregnancy. So it is always a prudent thing to get a sonography done. Now, in this case, she has been prescribed with the abortion pills, and very often now the differential diagnosis here is between either whether it is because of ectopic pregnancy which has ruptured and resulted in a acute ectopic and thus a shock as the patient is coming, or it could be sometimes because of excessive bleed. Like in cases of incomplete abortions, we have seen in patients who have taken medical termination, and then because again the gestational age was not very well ascertained, they sometimes end up with incomplete abortion, and thus they result in shock and come to the hospital.
But madam, here she has not bled. So the severe bleeding and incomplete abortion is
out of question. So the first differential diagnosis, of course, our needle points towards acute ectopic. Now, if you want further more differential diagnosis, then of course, if she was having severe nausea, vomiting, and resulting in different causes which may not be related to pregnancy, but her presentation is more towards ectopic pregnancy.
Yes, acute ruptured ectopic pregnancy you have pointed out, but it can be a tubal rupture.
Can be a
ectopic as well. Okay. So how would you go ahead with the management of this patient?
Yes. Now, in this patient, the prudent thing first is to manage the patient to take care of the shock first. So we would definitely try to improve her shock by giving her fluids at this juncture, because of course we have to do a complete thorough physical examination so that to rule out any other like pulmonary edema or any respiratory problems, they are not there. So we can give her enough amount of fluid to improve her blood pressure. We can give her inotropic drugs if at all they are required. And steroid can also be given to support the shock only at this juncture. Of course, simultaneously, a sonography should be done so that we immediately identify if there is collection or hemoperitoneum inside the uterus. But clinical examination, by now we all know that on just looking at the patient or by doing a per abdomen examination, we would find subumbilical distension more often, unless it is a very severe ectopic rupture and hemorrhage which causes the entire abdominal distension. But very often a subumbilical distension will be found localized tenderness may be there, it may not be there,
Madam,
depending
maybe go
again.
ahead. You have already told us that it is a case of acute ruptured ectopic pregnancy. May it be a scar ectopic or a tubal ectopic, that will be confirmed on ultrasonography. You have already talked about it. So when you are
Okay.
managing this patient, madam, you are going to correct the shock as you have pointed out, but you will arrange the blood and blood product. But what about the consent, madam? You want to take this patient for operative procedure. So how will you explain this? Why this patient has landed up into this condition? How would you explain to the relatives, and what are you going to do now? So what will be the consent like?
Yes. So immediately as the patient has come and having examined, we would definitely first inform the attendants who are actually in a very bewildered state. They don't know what has happened. So we have to tell them that the pregnancy which was there probably was not situated where it should have been, and it has now disrupted, and it could have been at the uterine cesarean section scar, but scar ectopic so early. Most often it could be a tubal ectopic, and tubal rupture has happened. Mostly there is a lot of blood inside the abdomen, and thus they would be better off by giving a consent
Okay,
for
madam. So you
laparoscopy.
have taken the decision. So whether you would go for laparotomy or laparoscopy, and whether you would go for salpingectomy or a conservative surgery, we want to know from you.
It all depends upon the expertise that one has. One who is an expert laparoscopic will definitely go for a laparoscopic correction of these ectopic pregnancies, whether it is tubal or even if it is a scar ectopic, they can be very beautifully treated with laparoscopy unless
Yes.
we
So
are
I
not
will
that
just
much.
interrupt you here. Why I'm asking you this question? Here it is said the patient is in shock. That means there is a lot of hemoperitoneum. So whether
Yes.
whether we should go for laparoscopy or go for laparotomy.
That is why I said it all depends upon expertise. But yes, as you are rightly pointing out, for the novices, it is always better to go for laparotomy when the patient general condition is not stable initially.
Yeah.
And regarding salpingectomy versus conservative
Yeah, in fact,
surgery,
madam, just to interrupt you, previously, I think maybe around 10-15 years back, we used to say this, that we should preferably go for laparotomy. But nowadays, we have such an expert laparoscopic surgeon that they can, suck out the whole hemoperitoneum and clarify
exactly,
and catch hold of the point which is bleeding, right?
exactly.
So
Yes, yes,
this we have to stick to it, that whatever facilities you have available, whether you have a expert laparoscopic surgeon and the entire gadgets available, you can go ahead with the laparoscopy as well.
exactly.
Yes.
Yes, yes, of
Okay.
course.
So
And regarding salpingectomy, one important thing I would like to suggest that
yes,
now that we have such good in vitro fertilization techniques available, there is no fun in getting repeated ectopics trying to conserve an already
perfect.
damaged tube. So
Yes.
salpingectomy should be the treatment in a patient who has ruptured tubal ectopic.
Yes, yes, yes. Now
Yes.
only what we have to learn from this patient. What message you want to give, madam, to the
The message
prescribing
is,
doctor? Yes.
am I to go give this answer now?
Yes, yes.
Yes.
We
So
continue
the
with.
message is very loud and clear here, though still our government of India has not included it in the routine of giving medical termination of means MMA, medical method for abortion. Ultrasonography is not mandatory, but
But
anywhere where the ultrasonography facility is available, it is always very prudent to get an ultrasonography done before prescribing medical method to make sure that it is an intrauterine pregnancy one and the sac is visible inside the uterus, that is two.
yes,
Even
yes,
if it is an intrauterine, it may not be sometimes visible so far. So there is no fun giving medical method if the sac is not visible in the uterus.
sure, yes.
It is better to wait
Perfect.
for a few
So
days.
even if by law it is not mandatory, it is recommended for the safety of the patient and for the safety of the doctor. So that is
Yes.
what should be the message. Also, when you are prescribing the medicine, you have to warn the patient about the signs which she has. If at all she suffers that she gets only spotting and the fainting attacks during that pain. If at all she gets
Yes.
fainting attack, very classical of that fallopian tubal distension, then if she
Yes.
that you have to warn her so that she has to report to you before she ruptures. So I think these are the things which you really want to, and whenever you are prescribing the medications for medical abortion, it has to be thoroughly, investigated, hemoglobin, blood group in RH type, and of course ultrasonography. These are the minimum investigation that should be done in the interest of the patient as well as yourself. And you have to explain the procedure and what are the warning signs that you have to explain the patient, and it has to be supported by all the backup team. So everything has to be properly explained. So thank you.
Madam, one more very vital thing is the
Please.
patient should not be alone at home while
Yes.
she is taking the medical method.
Very true.
That is also a very important thing.
The relatives have to be explained that she need not be left. I mean, she should not be left alone at home. And if at all she faces all these adverse symptoms and signs, what we are explaining you, she has to be immediately brought to the hospital.
Yes.
Very well discussed case, madam. And thank you so much. So,
ma'am, I just want to add one more point.
Yeah, please.
Ma'am, in today's world, over-the-counter distribution of the MTPPs should be prohibited. Because these are the ones
Prohibited. Don't you think it is prohibited? But if they are not following the rules and regulations, the medical stores are not allowed to keep the medications. In fact, it is to be prescribed by the registered medical practitioner in duplicate, and it has to be signed and stamped. That is what the rules and regulations say. But then it is not followed. Okay. So thank you so much. And now we go ahead with the second case. You have this 36-year-old woman who is, having 7 years infertility, and she conceives after IUI. Her husband stays in Dubai and she stays in a close by village. But because it's a precious pregnancy, she comes to you regularly for ANC checkup up to 24 weeks. You tell her that everything is fine. And so, happily she disappears for follow-up. At 34 weeks, she reports to a close by PHC, primary health care, with complaints of edema. So when the doctor there examines the patient, a BP is 176 by 116. Fetal growth is apparently normal. There is proteinuria. Okay. Her blood pressure measured at PHC was very high. So the medical officer gives her tablet nifedipine retard. Okay. She was advised admission, and she was just explained that maybe she will need early delivery or intervention. That is how the only thing she was explained. So she doesn't bother. She goes home, and after 2 days, she gets admitted to a higher center, that is the sub-district hospital. There again, the doctor finds that the BP is still very high, 168 by 110. And rest everything is same. So they feel that, the BP is very high. They just give her magnesium sulfate to avoid convulsions. And because they have an anesthetist and obstetrician to do this cesarean section, they go for Caesar. 1.8 kg live female child is delivered. And the patients, with tablet nifedipine, tablet labetalol, and Maxwell. Now she remains on 140 to 180 systolic and 100 to 110 diastolic still. Okay, very high blood pressure in spite of all this. So around 20 hours after the cesarean section, she suddenly starts getting severe cough, breathlessness, restlessness. Pulse rate is 115, blood pressure is 220 by 118. Her oxygen saturation drops to 70%, Dr. Pradnya. When you auscultate, her chest is full of wheeze, no clear breath sounds. What is your differential diagnosis here? How would you come to the diagnosis, and what is the management? You will go ahead.
Good evening, madam.
Good evening.
Happy Gudi Padwa. Ma'am, since it is after 30 hours of cesarean section, and the BP is already high, and the chest is wheeze, and oxygen saturation is 70%. So she is severe preeclampsia with pulmonary edema.
Perfect.
So
has any thought came to your mind that sudden severe breathlessness, and
ma'am, she can have pulmonary embolism,
right?
Embolism, amniotic fluid embolism also may be there.
Yes.
But because she's
preeclampsia, hypertension. Yes.
So more chances of pulmonary edema.
So how would you manage this patient?
Madam, the pulmonary we'll have to shift her to ICU first because
Correct.
she will need
But then
ventilation.
right now she has, collapsed. I mean, she's already having
70% with
yes,
oxygen.
yes,
So
yes.
we will
So
give
here,
her,
what
give
you will
her
do by the time you shift her to?
yeah, so we'll prop her up, give her
Mhm.
positive pressure ventilation, and start her on oxygen with the bag and this maximum 4
Yes,
liters and
100%
increasing.
oxygen.
Then we can give her nitrates, nitroglycerin sublingual tablet, and
Is
you can
it?
give her diuretics.
Why do you want to give nitroglycerin sublingual tablet? We should have some control in our hand, no? Suddenly, if she collapses suddenly, what is the antihypertensive of choice? I would say the other.
Madam, we can give her Lobetlol IV 80
Yes,
start
perfect.
with 20 milligrams IV, then we can
Yes.
increase it up to 40 milligrams IV.
20,
every
40, 80.
Yeah,
Then
ma'am,
you can repeat even 80. Yes.
every 10 minutes. Then we can also give her Maxelf also, ma'am.
Labetalol, how much maximum you can give? Because 220
Ma'am,
is one
220.
minute.
220 is the highest we
Yes,
can
yes,
give,
yes.
and we have to watch every 10 minutes. Like
Perfect.
only the bolus dose has to be given.
Okay, but you will give labetalol first, or you will give something else in addition to that? She's in pulmonary edema, you will give her Lasix, diuretics?
Yes, madam. Diuretics is the drug of choice. So we can give furosemide. And
How much? How
ma'am,
much?
80 milligrams.
Yes, it is, definitely more than 40. So you can give 80 because she's already, 220 by 1 minute. So you can definitely give, but at least start with 40
Start
milligrams.
with 40 milligrams.
Yes. Okay. So with AMBO assisted respiration, this patient was, getting shifted to ICU, and the way she, develops a cardiac arrest. Now what will you do? How will you revive her? You means whosoever, but how will you? What all measures? She's landed up into cardiac arrest.
Madam, we will resuscitate her.
How? That is what I'm asking. How?
Madam, ABC, the manual.
The cardiopulmonary resuscitation first. She's into standstill, cardiac arrest.
Madam, arrest, we will give CPR first. No?
Yes, yes.
So we lift the chin and push both the breasts laterally and start with the airway, then breathing, then circulation.
Okay. Okay, so after this, after 1 hour, this patient was revived and she had spontaneous respiration. Her blood pressure came up to 100 by 64, yet she was little confused. Okay, so you could, this diagnosis was pulmonary edema because there's lots of fluid in the pulmonary interstitial spaces. The lungs were, they had lost the compliance, and there was ventilation perfusion mismatch. There was increased work of breathing, so many things, and that is why you have to go for all this ABCD. Meanwhile, you will send all the investigations to confirm the diagnosis, X-ray, echo, and all this, even cardiac enzymes. You don't know whether it is myocardial infarction, also global infarct as well, but you have lots of ways here. So you may give her nebulizer as well as, steroids to relieve the spasm, vasopressors. Now, because initially she was having 220 by 118, but suddenly now her BP has come down to, after resuscitation, it has come down to 100. So meanwhile, her BP was very low. That is how it was. So definitely you need to resuscitate her. So the question remains, Dr. Shabana.
Yes,
hi,
ma'am.
Shabana.
Hi,
So,
ma'am.
yeah, hi. So was it preventable? Was this incidence preventable?
Yes, ma'am. Yes, ma'am.
If you
Definitely.
try to recollect the history and how, what went wrong and how, where we went wrong. Yes.
Ma'am, she was having, from the start of her antenatal checkup, she was having so many high risk factors. She was elderly with hypertension. Antihypertensive started to her was not the right choice.
Infertility,
Was
conceived with ART techniques. Yes.
And she was presenting with hypertension. Antihypertensive jo start with it was not the choice.
Shabana,
Be started.
I would take you a little earlier. These were the high risk factors, the maternal characteristics. We should have scored as a high risk with HTP.
Yes, yes, we have to do the
Should have
scoring.
started her on some preventive measures. What are they?
Yes, ma'am. We have to start her with aspirin 150 milligram. And
75.
regular, all the investigation should be done because she was the pro candidate to develop
Low dose
gestational
aspirin and high dose calcium and vitamin D3.
Yeah.
Okay, so aspirin 75 milligram and calcium and vitamin D. Okay, so at least calcium of more than 1 gram, that is what is recommended here. Okay, so these two preventive measures. So prediction and prevention, we have failed in that. Okay, and that's the reason. Now coming to the management, she reported to the PHC. Her blood pressure was 176 by 116, very severe hypertension. What was your drug of choice, Shabana?
Ma'am, in all the guidelines, for
Yes.
practical practice also, labetalol is only the drug of choice nowadays
Yes.
for antihypertensive.
And one more oral drug.
Started with
nifedipine.
Yeah, that was wrong. Another thing, when she was admitted, she was concomitantly given nifedipine plus magnesium sulfate, which is also not according to the guidelines and the practical practice also. The
You can
nifedipine
give.
in combination of
Let me-
Maxel therapy should not be given.
Let me clarify. You can very well give magnesium sulfate with nifedipine. Can you just tell me what is your view on this? I mean, why
My
we
view,
cannot?
various studies are showing that if the nifedipine along with the magnesium sulfate is given, there is a sudden hypotension sometime. Patient land up in a phase of cardiac arrest.
No, in fact,
The choice is
by World Justice Organization says that you can very well combine nifedipine, which is a calcium channel blocker, with magnesium sulfate.
Okay.
Magnesium sulfate is anticonvulsant. It is not antihypertensive, though little fall in blood pressure.
Vasodilation.
Yes, but when you have a patient of severe hypertension, when you need to give antihypertensive, that is nifedipine capsule, may be very easy and convenient to administer those who are not well versed with the IV labetalol. And then, of course, you need to go for magnesium sulfate to avoid eclampsia, right? So that is, you can definitely come on, but you have to be little vigilant, more vigilant than what you are usually. Okay, go ahead. Now, what else? So it
fluid should be restricted. We should not give an aggressive fluid therapy because these patients, they are very much prone for this thing of pulmonary edema.
Yes.
And permeability is quite high.
So the preload, when she was, being taken for cesarean section, the preload should have been restricted. As soon as the baby is delivered, what about uterotonics? Your view for this patient?
Yes, we can use uterotonic for this patient, but avoid methargine. Avoid oxytocin. Active management can be done by oxytocin, but avoid methargine.
Best medicine for this patient, best uterotonic is carbetocin, because carbetocin has got a preventive or a prophylactic role. Okay, and single shot of carbetocin is very, very effective. It is effective as long as one shot of carbetocin is effective as much as the infusion of oxytocin for 16 hours. That is what the studies are saying.
It's not available everywhere, ma'am. Sometime in government sector.
Okay, so done. So, but then you have to give the concentrated solution.
Concentrated, yes.
There you have to go for the fluid restriction. Perfect. Yes. Okay. What else? After the baby is delivered, whether there was a role of last 6 years, any diuretic?
Yes. Diuretic plays a very important role in these type of patients because they are very much prone of edema everywhere. Yes. So, we can go for even in post-operative period, we can go control of blood pressure only with the diuretic also. And also,
So I would suggest that once the baby is out, there is absolutely no harm in giving the diuretics, because you are worried about the intravascular compartment, which is restricted. So you are worried about the sudden hypertension, you're worried about the fetoplacental circulation. But once the baby is out, when you're giving fluids on this side, you can definitely use diuretics, which will, hasten the uresis, and that is how you can, avoid the overload in these patients. So, Shabana, thank you so much, and that was
thank you, ma'am.
Discussion from your side. Thank you. Now we go to Dr. Jagrati. Dr. Jagrati.
Yes, ma'am.
Yes.
So, very good evening.
Yeah, good evening. Good evening, Dr. Jagrati. We have this patient, 20-year-old primary gravida. She was admitted in in labor at a very small nursing home, nearby nursing home. Up to 11 p.m. She was there around 6 to 8 hours. She was getting very strong labor pains, but she was not progressing. So the obstetrician thought that she's landing up into obstructed labor. So she decided to go for cesarean section. When the sister tried to catheterize her, there was no urine. And then retrospectively, when they got the history, there was absolutely no urine since her last 6 to 8 hours when she was in hospital. She has not passed urine. Okay, so she was almost going into anuria. They had missed this. So now they shifted this patient to the bigger center or the higher center, and where the obstetrician examined her. The pulse rate was 110. BP was 110/70. Uterine contractions were very severe. There was absolutely no relaxation in between the uterine contraction, and the fetal heart was 100 to 120. The dilatation is not 7 centimeter, but it is 3 centimeter. That is by mistake. And membranes are absent, and there was little bleeding also from here. So what is the diagnosis for this patient, Dr. Jagrati?
Madam, as by clinical presentation, there is a severe uterine contraction and there is no relaxation in between. So that's suggestive of abruptio placentae, ma'am.
Perfect, perfect.
And there is a anuria also, because abruptio is mostly associated with renal complication due to acute tubular nephritis and acute tubular necrosis. And there is a possibility of conjunctive coagulopathy also.
So when we did her investigation, we found the hemoglobin is 8 g% only, platelets 1 lakh, and the PTINR was 2 and FPTT was prolonged. She had less of fibrinogen, only 150, and FDP, fibrinogen degradation products were present. Now, what is your diagnosis, Dr. Jagrati, and how will you manage? What all things you have to manage?
Yes, ma'am. First of all, stabilize the patient, and blood should be arranged. 1 unit fresh blood should be arranged. And
what is the role of fresh blood? Do we use fresh blood nowadays?
If blood product or blood
her BP is 110/70. So at present, right now, what you need is FTP is present, fibrinogen is very less. So she needs coagulation factors, okay, clotting factors. So she needs blood and blood.
FFP is not available, then fresh blood. But if blood component or FFP is available, then must be FFP should be arranged.
Okay.
Okay.
Okay, how will you manage this patient now? What all things she is in labor, the baby is inside, baby is in distress, she is in shock because this blood pressure 110/70 may not be her normal blood pressure. She may be having very high BP because of which she has landed up into abruptio.
Yes, madam. So this blood pressure may be shock to the maybe at present in the condition of shock. So first of all, stabilize the patient.
Coagulation failure and renal failure, all
Yes,
this
renal failure also, and patient to be taken for cesarean section as baby is already compromised.
Okay,
As
so
madam
I will
already
interrupt you
said,
here, whether Jagrati, whether you will take her for emergency cesarean section first, or you will arrange the blood and blood product first.
Blood and blood product must be arranged previously, ma'am.
Anybody else want to add something? Want to differ from here? Yes, Shabana, Dr.
We have to first deliver
the
immediate delivery is very important in this massive abruption cases.
Dr. Swati.
Yes, I am Dr. Vrinda Joshi, ma'am.
Rupture of membrane.
Yes, Dr. Vrinda.
Yes, of course. Now, these are the patients who need a multi-pronged approach, actually, where we have to do so many things simultaneously.
Yes, so the only answer here is in one word, everything simultaneously. Okay, there is no this first or no that. Yes, so that is very, very clear view on this. You have to be very clear that not this first. You go for cesarean section, you will lose the mother. You try and wait for the blood and blood products, you may lose the baby. Okay, so all these things simultaneously, that is the only answer here. Okay, go ahead, Dr. Jagrati. Go ahead with the management. Jagriti? Yes, anybody else can take up from here. Yes?
So simultaneously, blood should be arranged and patient to be taken for
Yes.
cesarean section.
By the time you give her lots of fluids, crystalloids, yes, try to maintain her, perfusion. She doesn't go into hypoperfusion once again. You don't, make her go into the irreversible renal failure, that is cortical necrosis, correct?
Ji, ma'am.
Okay. Then once you arrange everything, things are, even if you get the assurance that yes, you're getting the blood and blood products, you can start taking her to operation theater. Okay, what precautions do you take during this operative procedure? Dr. Nidhi, can you take this question?
Yes,
Dr.
ma'am.
Yeah.
Yeah. So, ma'am, as you have already said, all the blood products need to be ready. ICU bed should be made ready. So we have to ship. We might have to ship this patient next to the ICU for the ICU care. Fluid should be restricted. Like clear fluid should be restricted, like RL. We can go with the crystalloids, but if till the blood is being arranged, we should go with the crystalloids. But then fluid restriction should be minimal. Another thing is, as the urine output was 0, so we should be giving Lasix challenge should be given to this patient.
Perfect. That is what we are saying, that you have to give aggressive fluid therapy with the challenge of Lasix, that is post diuresis, right? You don't want the patient to go into irreversible renal failure. So once you get all the blood and blood products, you just go for cesarean section, deliver the baby. And now what? You have to see that this patient doesn't land up into PPH. She is already in APH. She is very, very prone for PPH for multiple reasons. Okay, coagulation failure. She may have uterine atony or covalent uterus. So many things. Okay, so how do you do that? What uterotonics you use?
I usually prefer giving carbitocin, and if it is not readily available, then oxytocin is my preferred uterotonic.
Yes, concentrated oxytocin.
Concentrated uterotonic. Yeah.
Definitely. And then, of course, you have various measures. We will hear about the PPH sooner. Once you expedite the delivery, achieve the hemostasis, avoid the overload, because you're giving aggressive fluid therapy, but you have to, for such patient, you may need the invasive monitoring as well. So you don't want this patient to go into shock. So what all things you have to correct when you're giving the fluid? What all you have to correct? Is it only the volume, Dr. Nidhi?
No, ma'am, it is not just the volume. The coagulation factors we need to be corrected. The electrolytes need to be corrected. Her ABG should be done so that she is not landing up in metabolic acidosis or this thing. And if we are giving a blood transfusion, if it is basically the coagulation factors should be available. If they are not available, if we are giving the blood transfusion, then chelation of the calcium carbonate need to be given with the blood transfusion also.
Yes. So it's not only the volume. That means you have to correct the hypovolemia. You have to correct the hematocrit, the oxygen carrying capacity. You have to correct the coagulation factors. You have to correct the electrolyte as well. Okay. So all these things you have to take care when you are giving the fluid therapy. So everything has to be taken care of. So that is how, with all possible arrangement and the teams ready, you can go for cesarean section, deliver the baby at the earliest, prevent the PPH and manage her shock. And of course, first 24 hours, you have to be very, very vigilant as far as even the coagulation factors as well. Otherwise, it should not happen that you're corrected initially and later again the process of, DIC, it can recur. Sometimes there can be what is called as dilution coagulopathy, correct? So you have to take a close watch on this. Okay. So thank you so much. Tell me, anybody wants to add anything?
One important thing here is that covalent uterus. It appears sometimes very, very grotesque. And that is just a passing word because it needs to be mentioned whenever we discuss abruptio placentae. that
Yes,
it is, even if it looks very grotesque, uterus is all black and blue and all, it will revert back to normal once the patient is okay.
yes.
So that
One thing
needs
I
to be
want to
kept in
add,
mind.
we can do a prophylactic balloon tamponading for these patients to prevent them for PPH. Sometimes they land up because these patients, they are very prone for PPH also.
Okay, usually I think the balloon tamponade, definitely if it is, you have a larger placental bed which is bleeding, definitely these are the patients which need and which, respond very well. So very good comment, Shabana. And we have now Dr. Nidhi, this is a case for you. You have this 32-year-old para-1 with previous LSCS, one LSCS. That was 1.5 years back. She has a male child. And during 6 months, because of her husband's job transfer, she comes to you with history of bleeding. And she has had bleeding at home. When she reaches your hospital, it has already stopped. But with further inquiry, she gives you history of spotting during early pregnancy. And there was one sonography report which, did mention that she's got a low-lying placenta. Now, when you do ultrasonography, the report is placenta previa with absent RP leg. The retroplacental sonolucent zone is absent. So this patient now at 30 weeks, again, she starts bleeding, she comes to the hospital and during investigation, she collapses. So what is your diagnosis and how would you manage this patient, particularly during this emergency? She has collapsed in front of you.
Yeah, mostly this is a case of bleeding placenta previa. As the scan has not been repeated after 30 weeks, this is mostly the most probable diagnosis is the of placenta previa one. Second, as the patient is collapsed, first the consent and information to the relatives need to be given. This could be the cause. The placenta is low lying that has bled.
Dr. Nidhi, I would interrupt you here. Is it only the placenta previa or something else in addition?
Placenta previa
finding here.
Accreta can be there.
Accreta
can be there.
Yes, because
Previous
no RP legs are seen.
Yes,
So
maybe.
Yes, it is a placenta
Placenta
accreta percreta, we don't know, but it is absent RP lobe. Okay?
Yes. Mostly it is placenta previa with placenta accreta or increta, depending. That will be confirmed after doing the MRI or the sonography for this patient.
We don't agree
Is
with
there a time?
MRI. Yes.
Ma'am, patient is collapsed right now, so we.
Yeah. So only one thing here. It is not. I mean, you just said it's placenta previa with morbidly adherent placenta. Okay. All of you agree on this? Okay. Good.
Yes, and this is so important, ma'am, because we have to counsel the attendants regarding the accreta. That is very important because
so
you
now,
may need a hysterectomy on table.
Yes, perfect. So now when
very
she has collapsed in front of you, how you will manage this emergency and how will you counsel and go ahead with the management? That is what.
Ma'am, first of all, I will counsel the patient's relatives. One, second, for the obstetric hysterectomy.
I will not allow you to counsel the patient and relatives first. I will say that she has collapsed. You put in two
Yes, she should be managed.
So you call for help. Call all your team. Okay.
Yes, ma'am. Yes.
Okay, perfect. Go ahead.
Okay. Ma'am, I think sonography by the side of the needs to be done.
Not now. You have to
Ma'am,
recover.
how will see how's the baby is?
Cameras used.
I would just say, how would you manage this patient first? So you have to
The shock
resuscitate this
needs to be
patient first.
managed.
Okay, resuscitate the patient first.
Patient need to be taken to the ICU. Resuscitation need to be given. A fluid should be given to the patient. Blood products should
Send her
be.
blood investigation. Send her blood for blood products.
Blood products.
Give your operation theater, your emergency anesthetist, neonatologist, your interventional radiologist, your surgeon ready. Because this is an emergency. Intensivist also. Yes. If at all you are in
Multidisciplinary approach needs to be done.
interventional radiologist. Okay, so multidisciplinary approach. So here we will say only call for help because this is your huge team you require. You have already landed up into the complication. Okay, then how you have to resuscitate this patient, and during this period when your team is managing the patient, either you or your senior colleagues who is well versed with the counseling process should talk to the relatives, should explain the procedure. So what will you explain? That what is the management? We will go into the retrospection later on. What will be the management for this patient at this point of time?
Firstly, we will
backside ultrasound.
Nidhi, Dr. Nidhi Rathi, she has collapsed in front of you. Whatever may be the diagnosis, you will not go for ultrasonography.
Yeah.
Bleeding.
First thing,
You have
call
to
for help.
open up.
2 large bore needles.
Large
To
bore
the OT directly.
That you have done already. Now you have, resuscitated her, put into ambulance. Your OT is ready. What operative definitive management you want to do?
Ma'am, I'll counsel the relatives regarding the obstetric hysterectomy will be required for this
Cesarean
patient.
section.
Cesarean section along with obstetric
Along
hysterectomy
with option. Yes, every word
will be required for this patient.
Every word matters, my dear. Okay.
Yes.
So cesarean section with decided, planned, elective, whatever word you want to use, pre-decided. Okay.
Pre-decided.
Why? I will just, make you aware, alert. Why you want to do this? Pre-decided, because this is a management, given in the books. But if you forget to take the informed written consent of obstetric hysterectomy, and once you start doing the procedure and then you come for the consent for hysterectomy, the relatives will feel that you have done something wrong, and that is why you are going for hysterectomy. Okay.
Okay.
So that's a very reason. This is a described management in the books. That is how you can tell them, if we want to save our patient, get her out of this emergency, we have to go for emergency obstetric hysterectomy, cesarean section with hysterectomy. Okay, that is what the consent should be. It should be, very high risk consent. Blood products, massive blood transfusion protocol, and then obstetric hysterectomy. In spite of this, she can go into DIC as well. That you have to explain to them. So you get everything ready, you get everything written, informed consent. And now, when you go for the procedure now, what are the special precautions for this cesarean section?
Incision, upper segment incision.
What about the abdominal incision?
Yes, ma'am. Upper segment, edge of the placenta.
Abdominal incision. I mean, because we take financial.
Ma'am,
vertical incision.
I'll prefer taking a vertical incision.
Ma'am, so
Yeah, line vertical incision.
Vertical incision.
Line vertical incision, because its exposure will be better with that. Second, the incision on the uterus should be above the edge of the placental margins.
Margins, yes.
Yeah.
It should be a liberal incision. The abdominal incision should be a liberal incision. That is very clear. Okay. If you say that I am very comfortable with financial, take a liberal transverse incision. But when we say ideally a vertical liberal incision. Okay.
Yes, ma'am.
Then what about the uterus? What incision?
Upper margin of placenta. Up to upper margin.
See, you have already mapped the placenta. Okay, you have already mapped the placenta. You take an incision just short of the placenta. Okay, see to it that you don't incise or reach the placental edge, which otherwise she'll bleed torrentially. Or go for what is called as a transfundal incision. That is a transverse incision on the fundus. Okay, that is very easy. Go for the transfundal incision, deliver the baby, don't touch the placenta, just apply green Armitage or, the clamps to the edges of the uterus and go for the obstetric hysterectomy. When you're sure of the diagnosis that this is a morbidly adherent placenta, absolutely no attempt to separate the placenta.
Neither
should not be given.
Agree?
Ma'am, one more thing I would like to add here from experience. The patients with previous cesarean section 1, 2, 3, whatever it may be, are having many adhesions inside the abdomen.
Yes.
So it is always a prudent thing to make the uterus free before we give the incision and deliver the baby.
Yes.
So that when we start the hysterectomy, there is nothing stopping us from delivering the
Very
uterus.
good, very good. That means you don't waste time in, separating the adhesions that time when the patient is bleeding. Right. That's a very good message. Okay, go ahead. Dr. Nidhi?
Yes, ma'am.
Anything else? So no attempt to suture the uterus, no attempt to, separate the placenta and go for obstetric hysterectomy. Total or subtotal? Tell me.
Ma'am, depending on the margins available to us, if it is a previous cesarean,
Yes.
it is very adhered, we'll not wait to separate the lower segment. It will bleed more.
Why?
Ma'am, we are yet not sure it is the morbidly adherent, is it is increta, percreta, or
Once you open the abdomen, you will see what it is. Okay? It will be right in front of your eyes. If it is percreta, that's a placenta will be the first thing you will see. Right?
Yes, ma'am.
The vessels running across the bladder and the myometrium. Okay? So if it is percreta, you will see it on its own. In fact, it has been, the people who routinely handle such cases, they say that in fact, it is good that you reach up to the cervix and go for a total hysterectomy, because that is what we want later on also. But then when you, try and separate the bladder, that traumatizes. In fact, even some part of the myometrium, the posterior wall of the bladder, if you have to separate sometimes, that is okay. People say that even if you injure the bladder, doesn't matter, you can suture it, but definitely you separate the placenta from the bladder and then go ahead for hysterectomy. That is what is discussed or described by the people who are routinely managing such patients. Okay. So in fact, it is good that you go for a total hysterectomy. Only in exceptional situations where it is absolutely very difficult or not possible to reach, up to the cervix, then I think it's better to avoid complications and go for a subtotal hysterectomy. Okay. Anything else now? Any precaution you want to take with this? You may have to go for the, the devascularization as well. Maybe sometimes, in spite of all this, the patient may land up into DIC and then she may bleed from the other side. That is why, prophylactic internal iliac ligation is to be done. Okay. Anybody wants to add here?
Ma'am, regarding the extent of removal, we in our hospital are having a very huge exposure to having placenta accretas of various types, ma'am.
Yes.
So from that experience, I am trying to tell you that the lowest extent of the placenta, because it's an adherent placenta, we have to reach below the placenta. Once the placenta is done, then recently we did a case, it was a previous 3 cesarean section, and the cervix was a tubular, almost 4 centimeter cervix untouched. It was only the scar which has gone into placenta percreta, almost reaching up to the bladder. So we reached up to the below the placenta, where all the placenta and everything was cleared. And the cervix, since it was not at all involved in the process.
Yes.
So that is the extent of removal.
Yes. Perfect. So, now we come to retrospection for this patient. Okay. So I ask you once again, Dr. Nidhi, what went wrong for this patient? She was, when she came to you in 6 months, you could diagnose it as, placenta previa accreta. She was a case of previous seizure. She gave history of spotting earlier. She had one USG report of placenta previa. In spite of all this, do you remember that this patient, she was not admitted? What would be your suggestions if she comes to you during 6 months with this diagnosis?
Ma'am, this patient needs to be admitted. The relatives should be well informed prior only. MRI should be done for this patient to know the extent at that time during the 6 months, and this need to be should be under the surveillance for rest of her pregnancy.
Yes.
And it should be a planned delivery, planned cesarean along with the consented hysterectomy at around 34 to 35 weeks.
Yeah. Yes. And even during this process of conservative management, the patient and relatives should be informed that all these strenuous activities, intercourse, internal examination should be avoided totally. Blood should be reserved all the time. In spite of all these precautions and being everything ready, she can land up into catastrophe anytime, because that is not in our hand, because it is placenta previa. Okay. So everything has to be very clearly explained. And then, why you have to go for elective procedure? Yes, Dr. Nidhi? Why do you have to go for elective procedure?
And because the only treatment for placenta previa is The
cesarean
is a
section,
cesarean,
obstetric hysterectomy.
yeah, with obstetric hysterectomy. So that's why it is always an elective procedure. It is never a.
Yes, but the reason, you are very
So
right.
that
The reason
so
for
that
this is
patient does
because
not
you
get
have a,
into the bleeding.
yeah, because
She
you
does
have
not
a,
land up in
this,
bleeding before.
Because we need a team.
you have an experienced
Yeah.
obstetrician, seniors around, daytime. Professor Vrunda Joshi, she is available that time. Then you have a team of anesthetists, senior anesthetists. You have a neonatologist and everybody available. You have the blood bank who is full-fledged working. You may get, n number of blood and blood products, whatever are necessary. If you are there, your multidisciplinary team remains informed. The intensivist, the interventional radiologist, because if you want to avoid or minimize the blood loss, you may sometimes go for the uterine artery embolization also. Otherwise, such patients may just bleed torrentially even when you open the uterus. By mistake, if you touch or incise the placenta, then she can bleed torrentially. So all these things, you have to keep it in mind. That is why all these special precautions. Now, once again, we introspect ourselves, what has gone wrong for this patient also, but why we could not detect and why we could not manage. So the RCOG guideline says that whenever you have this patient, having placenta which is low lying, that is 2 centimeter away from the internal os, you keep label the placenta is low lying, keep a watch. And then again, when you do the, the target scan, then you specifically look for the localization and the retroplacental space, as well as the, whether it is absent or so. And then you label her as having morbidly adherent placenta. And since then, the patient, Dr. Nidhi has very correctly said that you have to label her as high risk and go for, the management of conservative up to 34 weeks. Meanwhile, you prepare the fetus with the antenatal steroids and magnesium sulfate for neuroprotection. So I think that is all with our this placenta previa accreta. So anything else?
Planned delayed hysterectomy can be done, ma'am. Planned delayed hysterectomy can be done in PAS, ma'am.
See what the evidence says. Now I think we come back to the discussion what we have been doing 3 decades back. Previously, if it is absolutely not separating, basically I'm separating absolutely. Now that time there was no expertise in diagnosis of the management of placenta accreta, and there was the incidence was not so high. So sometimes when the placenta were totally not separable, that is morbidly adherent, people used to give a single dose of methotrexate and suture the uterine edges and with the placenta in situ, and then you just follow. But even we have done this, but it is absolutely miserable. You have to spend sleepless night, once and for all. Maybe you can succeed in this process, the placenta get necrosed and thrown out, but that is a very fortunate event. But otherwise, this patient can land up into septicemia, this patient can land up into embolization, and this patient can land up into torrential secondary
bleed, yes, emergency.
and then that hysterectomy is absolutely, on a moribund patient, it is the worst possible situation all of us can have. So I think a strict no, because whatever you do, your action should be supported by the evidence. Because we should have our parent organization's guideline, and Foxy ICOG guidelines say that absolutely no conservative management for the placenta accreta spectrum. Now, only reason for this, only indication for conservative surgical management here, a primary gravida patient with no living, issue, which is having, patchy adherence. It is not a complete adherence. So here you have that option for triple P procedure, but preferably here you have to go for, uterine artery embolization, or you have triple P. That is 3 things: placental mapping, stepwise devascularization of the pelvic vessels, and then patchy resection of the myometrium with the resuturing. That is how it is. But I don't think there is something of this sort, that is secondary or delayed hysterectomy. So I don't think we should be also talking about it. Okay.
Thank you.
Thank you, Dr. Nidhi.
Thank you.
Yes. So we have now Dr. Taruna, yes?
Yes, ma'am.
So I think with Akrita, I think we are done with all this. We have already discussed everything. Now we have this guidelines that also we have discussed. And we go to the next case now. We have discussed about this everything. I think the regional anesthesia, liberal incision, ample blood and blood products, the vertical incision on abdomen, on uterus, the sparing placenta, and of course the transpondal. Then this is the ureteric catheterization by the urosurgeon or oncosurgeon. And of course, whatever we have talked about that I've written, methotrexate has no proven role whatsoever when the uterus is conserved with the placenta in situ. Okay, so this was some questions here. Was it preventable? Yes, definitely this was preventable. And role of prophylactic os tightening? Absolutely no. Role of tocolysis? A strict no. Okay, what precautions to be advised that we have already discussed. And I can see Dr. Mahesh Gupta coming, joining the program. Welcome, sir, and we are eager to listen to you. I think we will stop here, or we take this last case, Dr. Swati, for you. Yes, Dr. Swati.
Good evening, ma'am.
Good evening. I think in short, I will just ask you to elaborate on the what blood and blood products you should give and how much quantity. That's
Ma'am,
all.
again, management of coagulopathy is a multidisciplinary or multi-committee approach. Anesthetists, emergency physicians, blood transfusion department, all we have to need together. And nowadays, ma'am, fibrinogen level is the main. First, we have to investigate the fibrinogen level. Then we have to go for the rotational ROTEM, rotational thromboelastometry. Recently, it is a very diagnostic to assess the early coagulation. And we have to maintain the fibrinogen level at least 150 milligram per DL to prevent the further DIC, the patient. Ma'am, we have to manage the coagulopathy to prevent the DIC within the 24 hours. If there is coagulopathy, we have to manage like that. The patient should not go in the DIC.
Okay. So fresh frozen plasma, cryoprecipitate, these are the available. Yes. Yes.
Ma'am, diagnosis have made
FFP, ma'am, and nowadays fibrinogen concentrate is the main course of the therapy.
Yeah.
As per RCBT guidelines, we give the 4 FFP and 10 cryoprecipitates if we diagnose the abrupt shear, ma'am.
Okay, so we finished we conclude our discussion here. This case, I will not ask you anything. I just want to give a message. This is a case actually. You can see here that it's a case where you have a large size baby, prolonged obstructed labor. You do cesarean section. It's a meconium stand liker. You deliver the baby. There's absolutely uneventful cesarean section. On shifting the patient to ward after 1 hour, she collapses. So what all things you need to resuscitate this patient. But when you examine, it's a non-hemorrhagic shock. The patient is absolutely, she has not bled intraoperatively. She's not bleeding now, but she is in shock. So bedside investigations were done and blood sugar level was very high, around 600, urine sugar 3+, ketones plus. So this patient was in diabetic ketoacidosis. So all of you know the management. I'm not going to talk about this. I will just give you a simple message here that, all of us are in, our parent organization, Foxy ICUG, everybody recommends that we have to go for universal screening of the pregnant women. That is, every pregnancy, every woman should be screened during every pregnancy for this hyperglycemia in pregnancy to avoid all these complications. And with this, I would conclude my discussion here and hand over the forum to Dr. Dipti, and I would request Dr. Mahesh Gupta to start his presentation. I would thank all of you, all the esteemed panel. Professor,
thank you, ma'am. It was very nice and very nicely discussed, Dr. Smith.
Thank you, ma'am. Thank you so much. Thank you, everybody. And over to you, Dr. Dipti. Thank you so much.
Thank you, ma'am. It was very, very engaging, and ऐसे लग रहा था that we were, just visualizing and reliving everyday scenarios that we deal with on a day-to-day basis. And it was a very interesting walkthrough with the all emergency cases. And we have Brijwala ma'am with us, who has been a very key person in execution of this webinar. And I would like to request Brijwala ma'am to please introduce and invite our chairpersons for this another interesting session, which is on conservative surgery in management of PCH.
Thank you, Dr. Sneha, for wonderful panel and excellent take-home messages. So we are moving towards our third session, that is by none other than by Dr. Mahesh Gupta sir, and regarding the uterine conservative surgery. And to chair this session, we are having distinguished faculties from Bhopal, Dr. Anita Shrivastava madam. She is the president, OBGY Society Bhopal 2325. And she had done her graduation, post-graduation from Bhopal, and she's associate professor at CMCH Bhopal. And she had been many posts in Bhopal OBGY Society, and she is trained in advanced gynae laparoscopic surgery. And now she is working hard for uh, preventing hysterectomies by MP government program to conserve the uterus. That is very, very important in need of the time. So I welcome you and Dr. Anita Shrivastava madam. And next chairperson is my very, very dear friend, Dr. Rachna Dubey. And we miss her every day in Indore because when she was here, we did a lot, many public awareness program, and she was instrumental in making all the events successful. So she is the Senior Joint Director, State Nodal Officer in Preventive Gynecology Center in charge, State of Art Unit at Kailashnath Kajju Hospital, Bhopal. She is program in charge, and she had done so many awareness programs in all over, not only MP, but all over. Whenever there is public awareness, we remember Rachna, and it becomes easy for us. She had trained 6,000 women screened and treated for cervical cancer in last 2 years. More than 2,000 women enrolled under government PCO centers in JP Hospital, Bhopal. And she had been awarded Harvard School of Public Health USA recently in 2023. And she authored Complete Contraceptive Technology, published by Health and Family Welfare Institute. She authored book Organ Donation, and I remember Rachna and Sir was instrumental in making Indore in organ donation #1. And she contributed chapters in various journals, gestational diabetes mellitus in JP publication. She had been awarded many times by state government, by ISAR, District Service Award by Women's Health, and Doctors Day Award, Radio My FM Award. So many things she is doing for the society, and particularly for awareness. That is very, very important. So I welcome you, Rachna, for giving your valuable time. So over to you to introduce our subject and our speaker.
Thank you so much for this warm welcome, Dr. Brijwala Tiwari. She is such a dear friend of mine. I do miss Indore a lot, and every moment, Indore is basically my second home. So we had a wonderful panel right now with beautiful selection of questions by Dr. Sneha ma'am. And at the outset, I would like to thank AMPOGS and AMOGS for inviting me at this webinar. We know that in India, we have PPH instances so high, 2 to 4% of the maternal mortality following vaginal delivery, and up to 6% in cesarean sections. And we all know our 4 T's, that is the trauma, tissue, tone, and thrombin, which are the causes of PPH. As Dr. Brijwala Tiwari has recently said that Save the Uterus campaigns to preserve the fertility and overall health of women is of utmost important call for the day. So there are many surgical sutures and procedures to manage PPH. So cesarean hysterectomy should not be your only choice. So here I would like to invite a very esteemed speaker, Dr. Mahesh Gupta sir, past president, Ahmedabad OBG Society. He has received 2 medals from Gujarat University in the Surgery and Medicine Department. He has also received Times of India Health Icon Award, Ahmedabad City 2018. He has developed, patented, and published various techniques to control PPH, which have been endorsed by RCOG. having American patent of suture material used for cesarean sections and PPH. He has a 50-bedded multi-speciality hospital in Ahmedabad. I welcome you, sir, for your presentation. Thank you. Thank you so much for kind words. May I share my screen now?
Yes, yes, definitely. Chitrakala, just allow. Yeah.
Is it visible now, my screen? Yeah, it's visible. It's visible.
You need to make slideshow.
Yeah, that I'll do. Now, is it visible?
Yes, sir.
Yes,
now it's the slideshow.
It is now moving. My slides are moving.
Yeah, they're moving.
Yeah. Thank you. So I listened some few sentences in the panel of conducted by Dr. Sneha. And Dr. Sneha, I am damn sure that after winning of your vice president election, when you will be going for a president election in Foxy after 5-6 years, you will negate all your things, all your sentences, what you have spoken today.
Definitely.
Because now the placenta accreta spectrum, most of the time the hysterectomy is not needed now. It is we Indians that we have a liberty to do obstetric hysterectomy in cesarean cases. But if you think the scenario of the Gulf countries and other countries where the hysterectomy is not allowed, so they are doing all cases of their placenta accreta spectrum conservatively. And in last week in Patna, I have invited a speaker from Egypt, and he had shown his technique also. And he told me that he is doing 95% of his all placenta accreta cases conservatively. Means uterine sparing. Yes. So we have developed our own techniques to conserve the uterus in all placenta accreta cases. And how we have developed that, I'll show you in my coming half an hour discussion. So as Madam rightly said that PPH is more common during cesarean section, 3.9% in vaginal deliveries and 6.4% in cesarean section. So cesarean section is more important than the normal delivery as far as the PPH is concerned. Because in these cases, the uterus is, abdomen is open and uterus is in your hand. So you should have some technique to control the PPH during cesarean section also. So today I'll only discuss the surgical management. I'll not discuss any other management, medical or conventional management, and that too with the uterine conservation in PPH only. That I'll speak today, because the obstetric hysterectomy is equally difficult and at times it is more risky. And I'll give you some thought-provoking ideas also. If you read our standard textbook of Williams Obstetrics, there is no clear-cut, guidelines that when to do a surgical intervention and what kind of surgical intervention is to be done, because most of the pages have been devoted to the medical line of the PPH treatment. So postpartum hemorrhage is not a medical emergency only, it is a surgical emergency also. Now, if you see the epidemiology of the global prevalence of the PPH, the risk of PPH is 2.9 times higher in emergency cesarean versus elective cesarean, and 5.2% higher in second stage of the labor. And it is more, maternal deaths are more common in cesarean delivery. That is 50 to 100 times more in lower middle income country like our setting. And maternal deaths driven primarily by peripartum hemorrhage. So 25% of the all women who have died in lower middle income country settings had undergone a cesarean section. So this is a global epidemiology of lower middle income country where the cesarean section is very risky. Now, the active management of the third stage of labor, all those teachers are present here. They have been teaching and we have been learning about the active management of the third stage of labor. We are giving oxytocin to each and every woman, irrespective of the PPH, because we don't want to have at least one PPH. So everybody is to be given oxytocin. That is called active management of the third stage of labor. Now, we should go for the fourth stage of labor, which is equally important, because in 1 hour, that is post-placental 1 hour or 2 hours is called a fourth stage of labor, where there is a proper uterine contraction and there is a proper thrombosis of the vessels present in the myometrium. No PPH will occur. Now, those women who died due to atonic PPH in India, they must have received probably all kind of medical management. then also they died. So that's why we have to concentrate on that spectrum of the patient where the medical management and other management fails. Although if we consider the 6% of the PPH rate, then a 1 lakh delivery in that 6% is 6,000, but death is only 100 per 1 lakh delivery. So that 5,900 will be cured by any means. But here we are targeting only that 100. So, but why all the times we avoid surgical means? Maybe our teaching, maybe our habit, maybe our attitude. And the second thing is line drawn between medical treatment and surgical treatment is not clear. The RCOG also has defined the cases where the PPH is more likely. These all cases require cesarean section. Now, straight away, I will go to the surgical management. Now, the madam told about the 4 T's. Now, as far as the surgical management is concerned, then the tissue, thrombin, tone, and trauma that causes is to be kept aside. Here we have to identify whether the uterus as an organ is bleeding or trauma to the organ is bleeding is from the trauma to the organ. If the intact organ is bleeding, that is upper part of the uterus is bleeding with intactness, that is the atonic PPH. And when the lower segment of the uterus is bleeding in cases of placenta previa or placenta accreta spectrum, then it is a lower segment bleeding. Or there is a bleeding from the genital tract trauma. So these are 3 basically different entities. So before jumping on the surgically to manage the PPH, we have to identify whether the upper segment of the uterus is bleeding or the lower segment of the uterus is bleeding or there is a trauma which is bleeding. Because these 3 things have different sets of surgery. Now, if we first go to the upper segment of the uterus is bleeding, that is atonic PPH. Here, the upper part of the uterus is flabby and it is bleeding. Here we have standard things. Either we can go for compression from the outside, that is various compressive sutures, or we can go for a stepwise devascularization, means to cut down the blood supply to that area. And this both the techniques, vertical compression of the uterus and uterine artery ligation or other vascular ligation, it is an established technique. And there are enough now data that suggest that both these things are very safe. So as far as the upper part of the uterus is concerned, there is no need to go for internal iliac artery ligation or hysterectomy. Just you will compress the myometrium and you will cut down the blood supply to the organ. Your work will be done. And even the prophylactic B-Lynch, in cases of the prophylaxis also it has been established. So in upper segment bleeding, the compression suture, cutting the blood supply or peripartum hysterectomy. Now the things what I have developed, that is called compression and occlusion technique, that I'll briefly discuss. It is easy, effective and speedier to control the PPH. It is reproducible. It doesn't require special assistance and it can be part of routine postgraduate study. This was first published in 2015 in the International Journal, and then it is trademark patented, and then it is published in the Springer Journal, Pan Asia Journal, and recently there is an original research article by a doctor who did the 50 cases of the COMOC MG, and it is published. And one more 10 cases series also published in the journals. And it is very well endorsed by the RCOG also. The RCOG separately kept the discussion on it in the London. Now the B-Lynch was the first person who think about the compressing the uterus and conserving the uterus in PPH. But B-Lynch is not much widely done by the doctors because the special needle and special sutures are not there. So here I have made a special suture to do a atonic PPH surgery, and this suture is now patented in US also. And how this suture works, that I'll show you in this video. Now every box of this suture having this kind of the paper in the box where there is a QR code, and anyone can scan this QR code in the operation theater in the event of PPH and can see this surgery. So this is an animation surgery. Dr. Sneha, volume is there?
No, right now.
Now?
No.
Okay.
You can voice.
Okay. I'll speak then.
Yeah.
So this is after the delivery of the placenta and the fetus, the uterus is to be exteriorized. Just straight needle of this suture is passed from front to back like this, and that is 2 or 3 centimeter below and medial to the cut edge of the uterus in case of cesarean section. Or in case of normal delivery, it is to be just passed front to back from in the isthmic area. So this is a one puncture on one side. So that is sufficient. Now posteriorly, we will have two separate suture strands, and anteriorly also you have two free separate suture strands, out of which one has a curved round body. Now corresponding free end of anterior and posterior will go up, and it will produce the vertical compression of the myometrium. That is a compression. COM stands for this compression of myometrium. Now the round body needle which is there, it will pass from the broad ligament at the same area or little below to anterior to posterior, and it will take care of the uterine bundle. So it will take care of the ascending branch of the uterine artery. So it is a mixture of a Hayman suture and O'Leary's technique. And similar procedure is to be repeated on another side. So two puncture on two sides, you are taking two modalities of the PPS tackling surgeries, that is vertical compression of the myometrium as well as the occlusion of the uterine artery. So that is a AMOGS MG. Now, how is the suture, and that I'll show you. So this is a
Mahesh sir, we can't hear the voice. You can speak simultaneously.
Pardon?
We are not able to hear the voice, so you can speak. You can give your voiceover for this.
Okay. Okay. So this is a suture separately made by the Indian company, that is Healthium Medtech. The one straight needle is there, that is 85 mm long, and that straight needle having a two suture strand which is attached to the straight needle. Out of two, one is having a round body and another is a simple long thread. So this is a 1 number polyglycolic acid, that is popularly called as a Vicryl. So this is a suture. Now, how it is to be performed? That you just apply the Alice's forceps on upper and lower edge of the uterus, cut edge of the uterus, and pass a straight needle from front to back like this. And you cut the straight needle. Now posteriorly we have two strands. So I will find out the corresponding anterior and posterior end like this. And then I will vertically compress the myometrium. My assistant will press the uterus, then release, then I will tie. He will again press the uterus and release, then again I will tie. Like that, we'll compress the myometrium. Now this round body needle is passed from the broad ligament to anterior to the posterior, like this, and posteriorly we will tie this. So what is the physiology of this technique, that I'll tell you in coming few sentences. So this is a live surgery I had shown. The second puncture is on a right side, like this. So this is a very simple and very effective technique if it is done in a proper time, particularly during cesarean section, where the cases of the RCOG define that multiple pregnancies, pregnancy with ART techniques, obstructed labor, and then you can close the uterus like this. So the physiology of this technique is basically it is a fourth stage of labor. In fourth stage of labor, two things happen. One is a compression of the myometrium, that is called myotamponade, And this proper myotamponade leads to a proper thrombotamponade. So I am doing a proper myotamponade by the vertical compression of the myometrium and a thrombotamponade by occluding the uterine vessels which is supplying to the fundal part. So just taking a uterine artery, I am making the endometrial flow more and more passive and venous, and which is taken care of by the compression of the myometrium. So two puncture on two sides, and you are tackling the two modalities. Unlike B-leach, where you need to go for a 6 puncture in the myometrium and with the compression only. So in vertical compression of the myometrium only, it gives a result of 75 to 90%. And if you are going for alone uterine artery, then again it will give you a result of 80 to 90%. But if you are going for this technique, you will get a almost 100% result. And Dr. Sneha, I am very happy to say that this guy in the Spain, when he had seen my technique on the YouTube, he made a special video in the Spanish language with this AMOGS technique, explaining this technique in detail with his model and in Spanish language, and he has presented this technique in the Spain annual conference.
Great.
And after watching his video, this is again a Spanish guy who did. This is Xavier Garcia from Spain, who did this surgery AMOGS, and he was not having a suture ready in his operation theater, so he take a straight needle there in Spain and made a suture like this, and then he performed the surgery in Spain, and then he sent me the video and in this procedure. So I'm happy to share that in Spain also the people are doing this surgery. So he made a special suture in operation theater like this, and he performed the surgery, that is AMOGS for atonic PPH. So that is about the upper part of the uterine bleeding with the conservation of the uterus, how you can conserve the uterus, how you can control the PPH. Now we come to the lower segment PPH. That is a placenta previa accreta bleed. It is very important to understand, and it is very important nowadays. The more and more cases are coming to you with placenta accreta, and it is a mind game. All the gynecologists, they are scared of placenta previa accreta or accreta spectrum. So how it can be tackled, that I'll show you in few videos. Again, if you search on the net that how placenta accreta spectrum cases to be managed, there are no exact details have been given. So in placenta accreta spectrum, the majority cases are the accreta only, that is 75 to 78%, while increta are 17% only, and while percreta is only 5%. So you are mostly dealing with the accreta that you have to be seen. Now, as far as the placenta accreta, or that is accreta means A stands for adhesion. So placental adhesions may be in the upper segment, it may be in the lower segment, it may be a partial, it may be a complete. So in upper segment, it should be dealt with another technique. When it is partial also, it will be dealt with another technique. And if it is a lower segment complete, it can be dealt with the other technique. So I'll show you few videos. How this is a fundal focal accreta. When you pull the placenta like this, one part of the myometrium get flabby, and you will find a gush of blood like this. So this is a fundal focal accreta. And now I'll show you the total fundal accreta. So nowadays, my referral center is getting at least of the half of the Gujarat cases of the placenta accreta. So every week we are getting many cases of the accreta, and we are dealing with these cases. So this is a total fundal accreta. And nowadays we have developed a technique that in total accreta also, we cut down the placenta and separate the placenta as far as possible with a sharp scissor, and then we can conserve the uterus. Because of the paucity of the time, I cannot show you all the videos what we are doing. Now, if we go to the discussion for the placenta accreta spectrum, if you are a young gynecologist, if you don't have any other access, then you have to go for a temporary tamponade of the bleeding. So here basically the success is a tamponade of the bleeding. It may be a temporary tamponade, it may be a definitive tamponade. So if you are young, you don't have any other access to how to deal with these cases, just you can do a temporary tamponade. So I'll show you how the temporary tamponade will work, and it will work very, very good. So this was a case of placenta accreta spectrum, lower segment. After the delivery of the fetus, the placenta was not disturbed. You can see the gush of blood. So here, just I am exteriorizing the uterus by pressing from the back in the broad ligament. I am passing a Foley catheter in the broad ligament on the either side, like this. So this is called a temporary tourniquet of the uterus. And you can easily stop the bleeding because it is arteriovenous blood. It is not a purely arterial blood. It doesn't have a blood pressure of 120, 130, but it is arteriovenous blood. You just apply a tourniquet, that is a Foley tourniquet or infundibulum or infant feeding tube. But Foley tourniquet is better because it is a latex material, so it gives a proper compression. And then you can decide for obstetric hysterectomy or a conservative means. Or else what you can do, if there is a more bleeding in the lower segment, you can use this Satinsky kind of clamp by putting on the either side of the uterus by making a rent in the broad ligament. And this technique also I have published in 2015 in the international journal, that putting a Satinsky clamp to control the lower segment bleed temporarily, then you can ask for the help, or you can ask for the arrange for the blood, or you can call for other help. So this is a very simple technique. You can put a Satinsky urological clamp in the uterus, but this is a temporary means, or this is a temporary tourniquet. All bleeding will stop like this. So this is about the temporary tourniquet. Now, initially we have started almost 8-9 years back. We were going for the FIGO approach and the WHO approach, that all the accreta cases, diagnosed accreta, we used to put we used to call a urologist. Urologist used to put a ureteric stenting on the both the side, and then we were performing the obstetric hysterectomy as it was suggested by FIGO and WHO. Now, after doing 10-15 hysterectomy like this, in post-operative specimen, when I examine the specimen and when I try to separate the placenta from the specimen, most of the cases I was successful in separating the placenta from the uterus. So then we have stopped doing obstetric hysterectomy in all the cases. Now obstetric hysterectomy decision we are taking on the table after taking out the fetus. So we have stopped now doing obstetric hysterectomy. Now then we have started. Now we before when we have started doing the obstetric this conservative approach, we were doing another technique. Here the bladder was separated, and you can see the placenta. You can see the placenta almost to the serosa, because this placenta has been eaten up the myometrium, and placenta is visible. So here we give a proper time first to separate the bladder, because once the fetus is out and the bleeding is there, then the separation of the bladder will be a little difficult. Now, these all cases are being done with the now regional anesthesia, all cases with the financial incision or a Joel Cohen incision with the St. George kind of rectus sheath incision, where the rectus sheath is open little 2 inch above the primary skin incision. That is called a St. George incision. And placenta is not separated, hand is pushed towards the fundal side rather than the cervical side, and then take out the fetus, and placenta is not to be disturbed. Otherwise, there will be, once the fetus is inside and you separate the placenta, there will be a torrential bleed. So first the baby is to be delivered. Then we were used to separate the placenta. And then we were going for a conservative means. We were taking the, see, after separating the placenta like this, there is a bleeding. Still some placental major tissues are there. Now the bladder is separated. This was before 7-8 years. Now we have modified our technique. Now what we are doing, that I'll show you. This is still we were not satisfied because there was a bleeding. So this is called a cervical isthmic suture that now we have developed. putting a cervical dilator in the cervix. And we are taking a 2 suture on either side of the cervix as low as possible. And you will find that after putting a 2, this is the right side of the cervical ischemic suture like this. And then you will appreciate that we wait for one minute and then remove all the packs. You will see the all bleeding will stop. So this was a case of placenta accreta. The bleeding is stopped, but there was a little more bleeding. So initially we were not ligating the uterine. See, this is a placenta still adherent in the lower segment, because most of the time the placenta is adherent to the scar of the cesarean section previously, like this. So here, if you take both the uterine artery, then all the bleeding will stop like this. And sorry. See, this is another side of the uterine artery. Just uterine artery is to be taken with a 50 mm round body needle from front to back, and back to front. There's just 2 uterine artery taken is sufficient. It will stop all the bleeding most of the time. So then now we have changed our technique, that when we are not disturbing the placenta, still placenta inside, we don't do anything. We just first take 2 uterine artery like this, and still placenta is inside. We are not in hurry. And you can see there is no bleeding because it is accreta and placenta is adherent to the lower uterine segment. And uterine artery is to be taken as low as possible, anterior branch and posterior branch also with a single puncture like this. We can easily take. Now after taking both the uterine artery, then we start separating the placenta. Because once you take both the uterine arteries, then the blood flow to the placenta will be even 60 to 70% will be cut down. So now you separate the placenta like this. So there won't be much bleeding. There is no space in the placenta and lower segment, because lower segment has been almost eaten up by the placenta, and I am just pulling the placenta and separating with the finger. The placenta is to be separated, and uterus is to be conserved very easily, and there is no much blood loss. So finally, we have developed a technique called a cervicoischemic suture. The bladder is to be dissected as low as possible. The Sargent retractor is to be placed in the pouch of Douglas like this to prevent any unnecessary puncture of the intestine or omentum. The large bore cervical dilator is to be placed in the cervix. Now this again, a new suture have been made, and it will be in the market soon. The 2 straight needle on either side. Now I pass a straight needle just lateral to the cervical dilator on one side, and another straight needle, because I am a right-handed person, I prefer to go from front to back. Another straight needle in the substance of the cervix, just at the level of uterosacral posteriorly or just above it, and tight. So whatever the blood anastomotic channel, vascular channel, which is coming up in the lower segment to supply the lower segment, it will be all stopped. So 2 suture on either side on the cervical dilator will take care of all your placenta previa and placenta accreta bleed. So this is a cervicoischemic technique. So now finally what now we have started our technique, that phalangeal incision. Now if you see that initial incision was, skin incision was quite low, but rectus sheath has been cut quite up. So that is a St. George modification of the rectus sheath incision. You can see this. The skin is cut here, but sheath is cut almost here. Now we go as high as possible and then separate the Now upper part of the fundus, transverse incision is placed. Again, hand is to be placed on the upper side of the fundal area, and then fetus is to be delivered. We have all the cases we give 1 gram tranexamic acid preoperatively. Now the bladder is separated like this. Still placenta is inside. So we are not in hurry to separate the placenta. Let the placenta to be inside. And we separate the bladder and bladder from the uterus. And in case of placenta acarita, generally there is a ballooning of the lower uterine segment. So bladder will be, most of the time will be easily separated like this. And give enough time for the bladder for separation, and see that it should not be bleed much. Otherwise, your half of the energy will be lost in to control that bleeding. And we are using this cautery also to separate the bladder most of the time. Now, after separating the bladder, we take a uterine artery like this. That is a 50 mm round body needle. We are using 180 centimeter long suture, one side having a 40 mm cutting needle and another side having a 50 mm round body needle. That is again available with 2180 mg code, Vajka code. Now, a right side of the uterine artery is taken. You just watch it very comfortably, and there is no much bleeding. So you are not in much hurry. If there would have been more bleeding, then I would have put a Foley tourniquet, and then I will do my further procedure. But here there was no much bleeding, so I was comfortable. I have not put a Foley catheter or Foley tourniquet. And take both the uterine artery first. So the first step is Foley tourniquet. If more bleeding, no more bleeding, then just separate the bladder as down as possible. Take both the uterine artery. Now you try to separate the placenta like this. Because after taking the uterine artery, the bleeding will be little less like this. And now there is a bleeding from the lower, from the cervical region at the lower edge. Now we'll put a cervicoischemic suture like this. So first on the left side, we are putting a cervicoischemic suture, and then on the right side, like this. And dilator is inside. So just dilator, it should be kept there, because we should keep the drainage channel patent. Now, once you take the uterine artery and both the side of the cervical ischemic suture, there won't be bleeding. Now you can put an additional full thickness transverse myometrial suture like this on the anterior myometrial wall, and the full thickness posterior myometrial wall also suture like this. We can take a full thickness posterior wall myometrial suture like this. See, like this. And then there won't be any bleeding now. Everything has been stopped now. And small oozers, they can be taken care of like this, all small oozers. And then a uterus is to be closed most of the time in interrupted suture, because the lower segment is so thin. We dissect the lower segment, we cut down the thin part of the lower segment, and we refresh the edges of the lower segment, and then we do like this, interrupted suture, box kind of interrupted suture. We do it. So this is our now latest our technique in all placenta previa cases, where hardly we require 3 or 4 mops and almost no bleeding. Now the last part of the PPH is a traumatic PPH. Here the organ is not bleeding, here the vessel is bleeding. So here there is a role of internal iliac artery ligation. And why the internal iliac artery ligation doesn't work in lower segment bleeding or atonic bleeding? Because it has an anastomotic channel. Anterior division branches have anastomotic channel from the posterior division branches from the femoral, from the internal external iliac, and from the aorta. So that's why it is not work. So in traumatic PPH, broad ligament hematoma, rupture uterus, episiotomy, huge hematoma, cervical trauma, colporexis, supralevator hematoma, all this PPH you need to go for a internal iliac artery ligation. And it is our routine that we go for we go via posterior approach. Just antivert or antiflex the uterus, apply Babcock on the infundibulopelvic ligament, lift the peritoneum, and separate very easily. You can see the ureter, and with the finger you can easily reach on the triangle. So this is almost sort of a unedited video like this. And you can easily reach with the finger. You can separate the loose peritoneum. Now just you have to break the sheath of the vessel. Once you break the sheath of the vessel, then you can easily do the internal iliac artery ligation. It is again not a very difficult job with the experience hand. Just you have to break the sheath, which is thick sheath over the artery like this. You can break the sheath with the either scissor or with the mixture. And once you break the sheath, then you can pass a mixture easily. So this sheath is almost broken now, and you can see the artery. You break the sheath on the either side. So mixture will pass between the sheath and in the vein, not between the. It should be passed between the artery and sheath, not between the sheath and the vein. It's always. If it is passed between sheath and vein, you can puncture the sheath. So internal iliac artery ligation for a traumatic PPH. So so I'll not go detail in this traumatic PPH rupture uterus. So upper segment PPH, AMOGS, lower segment PPH, cervicoisthmic and uterine artery ligation, and traumatic PPH is internal iliac artery ligation. So that's all about the quick recap of the surgical management of the PPH with uterine conservation. Thank you so much, Sneha, for patience hearing. Thank you so much.
Thank you, Mahesh sir. I would make a comments little later. I think I would invite the chairpersons to make comments on the presentation first.
Yes, madam. Dr. Anita Srivastav here. It was very nice lecture, madam. Sir, you have deliberated the topic very nicely. All the videos were very nice, and we learned a lot from you. I saw you doing this thing almost 8 years back, and you improved many, and you invented many new sutures and steps and this thing. And saving the uterus is now the in thing. So if we can save the uterus in past also, that will be a very great thing. And while you were doing your surgeries and it was all unedited video, the bleeding was very less. So we can try this, and with expert hand and with all the teamwork, I think each and every one of us will learn this technique and will go through it. And the best part was the QR code on each of your suture, so that if we miss some step, we can see that then and there and proceed. So that was one of the best thing. Nice learning you from sir. Namaste.
So that's why I told
Mahesh
you.
sir, if you can stop sharing, please. Stop sharing so that everybody can interact with you.
Just a minute. Yes. So that's why I've spoken that when the Dr. Sneha Bhuar will be contesting for Foxy presidency.
Yes, sir.
He will agree to all this thing. It will take
Yes.
3-4 years.
With years we will improve, sir. With years we will improve.
So,
Yeah.
So
And
thank
in
you so much.
obstetrics, the seeing is believing. That's what I believe.
Yes, exactly.
Because theoretical lecture has no value in this obstetrics kind of surgical thing. So that's why I'm doing the recording of all my cesarean section and all my non-descent hysterectomy, all. So I have almost more than 500 good recording of the cesarean and hysterectomy.
Yes. So what I was talking to, I mean, about your talk, when, I was at the end of my talk, I was just talking about, when you have primipara, no living issue, you want to save the uterus, then you find out the way. So when there is a will, there is a way. I'm sure you must have handled so many cases and build up so much of courage to come to this stage. So hats off to you, Mahesh, for your, very effective as well as very useful work for all over the obstetricians all over the world, and that's the very reason you're getting so much of appreciation. Secondly, I want to say that every champion is a contender once who just refuses to give up, and I'm sure you are the one who has refused to give up on this, and you have come to this stage where people are learning to manage the placenta accreta spectrum, and where you are teaching them. So it's the learning, unlearning and relearning that we have to not only manage the placenta previa accreta, but we have to save the uterus. And the videos, original unedited videos you have shown, I'm sure many of us are inspired, and they will have courage to go ahead with such procedures, of course, with due care. I'm sure such workshops under your guidance will definitely lead the way, and that is the need of the hour. So thank you so much for accepting the invitation and demonstrating also. Still, we want to learn. If at all you have some few things to share also, we are here to listen to you.
And basically, I believe that when you are doing a cesarean section, during the cesarean section, one should behave as a surgeon rather than the physician. When you are doing cesarean section, means you are a master. You have to stop that bleeding by surgical means.
Yes.
So during cesarean section, I don't think there should be any shortcut. So once you close the abdomen, you should be rest assured that this patient will not going to bleed. So there is no trial and error kind of thing in cesarean section. Because in medical colleges or in other big hospital, it is okay. But when you are doing a private practice, you are the only boss and you are the only responsible person. So once you close the abdomen, you should be rest assured that this patient is treated completely by me, and I'll close the abdomen. Thank you, madam.
One last comment from me, that because we are believing in the whatever is mentioned in the books, we need backup of the evidence. So because you're doing so much of work, I think it should come as evidence to be followed coming years. So it's a request to you that definitely you compile all your data and let us have your study as the evidence in our textbook also.
No, regarding your comment, let me put one more comment.
Yes.
There is a difference between science and maths.
Correct.
When the maths invented, 2 plus 2 is always was 4, is 4 and will remain 4. But science keeps on changing. So what the before 50 years or 15 years has been written by somebody, it keeps on changing. You can always challenge it and you can always change it.
Yes.
So
we expect it from you, because we may have to unlearn and relearn about all these procedures. These are really appreciable, Mahesh. Thank you so much.
Thank you everyone. Thank you very much.
Thank you so much. And over to you, Braj.
Thank you so much, Dr. Sneha, for making it so important webinar. It is all your efforts, and we could get so good speakers, and Mahesh sir is always excellent. Every time it is revising again and again, and it is mesmerizing surgery, and to prevent the uterus, to preserve the uterus, that is very important. And that is so simplified way you are doing, sir. ऐसा लगता है बस जाके हम शुरू कर दें. I saw you long back, I think 14-15 years back, you were doing this thing, and excellent panel by Dr. Sneha. It was case-based, and all panelists were superb. A concise talk by Sarita madam. So it is wonderful webinar. Rightly said by Bindal madam that there is so many webinars are going on, but this was like with so many take-home messages. So thank you, our chairperson, Dr. Anita Shrivastava madam, Rachna ma'am, Dr. Rosa ma'am, Manik ma'am, and all the panelists, Dr. Richa, Dr. Nidhi, Brinda madam, Jagruti, Taruna, Shabana for wonderful inputs. Thank you so much. And Deepti is there?
Yes, ma'am.
Yeah, Deepti wish to. Can you wipe it now? You are muted or voice is coming loose?
Yeah.
Thank you so much.
So I think that brings us to the end. Wonderful, a very stimulating, a very motivating webinar. And like everybody has already mentioned, I would reiterate that, there were clear-cut messages, and imbibing those messages and learning points in our practice, if we can save any minute for any obstetric patient, and if it translates into saving any life, then the purpose is fulfilled. And extremely grateful to the organizers and conveners of this webinar, respected Sneha Bhuyar ma'am and Brijbala ma'am. Best wishes to both of you, ma'am, for the upcoming elections. And your consistent hard work, I'm sure, is going to bring rewards. Extremely grateful to AMOGS office bearers, Kiran Kurtakoti sir, Bipin Pandit sir, Pardeshi sir, for joining in. Extremely grateful to our esteemed chief guests, my teachers, respected Jyoti Bindal ma'am and Kavita Singh ma'am, to our chairpersons, Rosa Oliai ma'am, Panse ma'am, Anita Srivastav ma'am, Rachna Dubey ma'am, to our learned speakers who did full justice to the very, very important topics, Sarita Bhalirao ma'am and Mahesh Gupta sir, moderator Sneha Bhuyar ma'am, and whose panels are always very, very practical and case-based, and the learned panelists, respected Joshi ma'am, Pradnya Harshe ma'am, Shabana ma'am, Jagriti ma'am, Nidhi, Renu Jain ma'am, Taruna ma'am, Swati, Richa ma'am, and to the organizing technical team for seamless execution and streaming of the webinar as well.
Thank you so much. Thank you so much, everybody. I have
ma'am.
self-welcomed and thanked everybody. I just make an humble appeal to all of you. Support me, my candidature for the Foxy Vice President from West Zone in the upcoming elections. And please do support and vote for me during the elections in August. Thank you so much.
Thank you, ma'am. Thank you so much. Just a moment, I will also appeal my own MP Society office bearer to support me for
My dear,
Health Committee chairperson. Thank you, Sneha, for giving this opportunity.
Yes,
Thank you so
AMOGS
much.
and AMPOGS has been a long association, and even as breast committee chairperson, we have had lots of programs as AMOGS and AMPOGS. So let us grow together and be successful together. Thank you so much. Together, all of us can make it. Thank you so much.
Thank you, ma'am.
Thank you, ma'am. Thank you. Bye-bye. Special thanks to Braj and Dr. Deepti. Thank you so much.
Thank you, ma'am.